Welcome back. So, as we have been doing this since yesterday, I think some people will be knowing about what are the questions we have been discussing. And have you tried those questions, Eva? So, all these questions, do you have any doubts or you want me to solve anything? If anyone wants to solve any question, I'll solve. Otherwise, we'll move on if you are able to solve everything. Hello? Right, but some values are missing the question. I don't think some values are missing the question. What question you want? Okay, you want to solve some question. Okay, so let us take a case 5 for example. Suppose if you want, we'll do case 5. Case 5, you have a sodium of 144, potassium of 4, slight hypernatremia. I won't call it as hypernatremia, but slightly, like your sodium is on the higher range, chloride 110, bicarbonate 24, BUN 18, creatinine 1.8, a little high, sodium a little high as well, and serum osmolality is okay on the higher limit of normal. 285 to 295 is normal, so it's slightly higher. Urine sodium is 30, okay, but it's a little less, but that's fine for me. Other values are not given. Urine osmolality is 204. Definitely it is less than 300, and urine volume is 4 liters. So they have given that the serum glucose is 90 and calcium is 9. So just to make sure that what's going to happen. So what is the, solution here? So like I'm dealing with the case of hypernatremia. That's the case here. Case number 5 we are talking about. And the patient's urine volume is more than 3 liters. Urine output more than 3 liters, suggesting this patient is having a polyuria. And of course, the patient is also having a dilute urine, in the sense like 4 liters is passing, but the urine osmolality is only 204. So which means he's passing a dilute urine as well. So what is the diagnosis? Hypernatremia, passing a dilute urine with a low urine osmolality. What is the probable diagnosis here? Any idea? You can take 20 seconds of time. That's the idea, isn't it? That's the thing here. And having a slightly elevated serum creatinine. Slightly elevated serum creatinine is there, 1.8 is there. So any idea regarding what actually we are dealing with here? Yes, Uday Bhaskar told we are actually dealing with the diabetes insipidus here. So in exam, usually the approach to hypernatremia is very important. So whenever you have a patient who's suffering from hypernatremia, the first thing I'll be generally looking is for the urine osmolality, which means I need to know whether they are passing concentrated urine or whether they are passing dilute urine. Suppose urine osmolality is more than, probably I can tell 600, or the urine osmolality is less than 600. So this is only a like overall approach, and this is only an approximate approach, and the actual treatment of hypernatremia is quite tough and difficult, and you have a lot of other things which has to be calculated. But for exams, I can tell more than 600 or more than less than 600. If I see more than 600, which means I'm passing a concentrated urine, which is, I feel, appropriate probably for the hypernatremia I'm having, because whenever I have hypernatremia, I'll be having a hyperosmolarity, because sodium is one of the very important constituents that determine the osmolality of the blood. So because if you see the formula for serum osmolality, you would have known that 2 times multiplied by sodium plus blood urea nitrogen divided by 2.8 plus glucose by 18 is the formula for serum osmolality. We discussed yesterday itself. So sodium is a very, very important compound that is going to determine the serum osmolality. And serum osmolality would have been very high. This would have definitely triggered ADH to be produced. ADH will be produced in excess. If ADH is produced in excess, urine will definitely become concentrated. They increase the urinary concentration, because ADH tends to reabsorb water from the kidneys. We know that. So whenever the concentration is high, I feel that must be considered as appropriate entity. But nevertheless, now I need to know the further causes, whether it is extra-renal, water loss. I mean, which means here I'm losing water. That's why the blood is getting concentrated. Whenever I have a hypernatremia, means I'm having some element of water loss. Or there could be a sodium overload. But remember, usual scenario, why I develop hypernatremia is because of the water loss, not because of sodium overload, but very rarely it could be sodium overload. To find out whether it is due to water loss or whether it is due to sodium overload, I need to find out what is the urinary sodium. So now the patient is doing a concentrated urine, but still I need to see the urinary sodium. If the urinary sodium is very low, for that matter, if it is less than 25 for our basic understanding, so I can suggest that this patient is not having a urinary sodium, urinary water loss, but on the other hand, he's having an extra-renal water loss. Extra-renal water loss. So in the form of probably the patient is having a sweating GI water loss, for example. A lot of your osmotic diarrheas can produce this kind of a picture. So I can think about a gastrointestinal loss of water through some form of diarrhea or vomiting, or could be high-grade fever, like insensible water loss, or the patient is having living in a desert or going in a desert where they are losing a lot of water in the sweat. So that's what I think. Or the urinary sodium is going to be high. In this situation, if I see if it is going to be more than 100, then the reason for high concentration of the urine and the reason for high urinary sodium is basically the sodium overload that is happening. So sodium overload is the reason for hypernatremia here. That's why they are passing all that sodium in the urine. That is actually raising the urinary concentration. At the same time, it is actually trying to increase the urinary sodium values as well. So this could be like seawater drowning. So drinking a lot of seawater. That's not common, but still one common example is drinking a lot of seawater could be a common example. Or if the patient is probably getting infused with sodium chloride containing solutions, probably it's a high-grade infusion of 3% NaCl or 0.9% NaCl. But in general, usual scenario which results in this kind of thing is 3% NaCl only, not 0.9% NaCl. Or the patient is receiving excess amounts of soda bicarbonate infusions which contain sodium. So this could be probably one of the reasons. Whenever the urine osmolality is less than 600, there could be some reasons for the dilute urine, still the patient getting hypernatremia. Probably the best thing I'll talk about is diabetes insipidus in this setting, or probably I'll be thinking about my loop diuretic use, because loop diuretics also produces isosmotic urine, because the urinary concentration by loop diuretics will be isosmotic. It will be equal to that of the plasma. So very rarely it could be osmotic diuresis. Osmotic diuresis. Clear? So these are the three probable causes. In this particular example, I'm having a low urine osmolality. Typically, where is that? Dilated urine means osmolality is less than 300. So low urine osmolality. At the same time, I'm having a hypernatremia. So any one of these could be a possibility, either a diabetes insipidus or a loop diuretics, or probably even a osmotic diuresis. So this all could be the possibility. Suppose to differentiate all these things further, either I need a proper history, or probably I'll be needing some other like parameters like the solute concentration of the urine. I will see the total number of solutes in the urine, that is 24-hour solute concentration, could be giving a clue. But nevertheless, we know what you mean by diabetes insipidus. Diabetes insipidus is due to reduced ADH or ADH resistance, defective ADH action. Defective ADH action. But here the clue is that the patient's serum creatinine is a little high, suggesting that very likely it must be a defective ADH action, which means it should be an ADH resistance. Whenever you have an ADH resistance, we call it as a nephrogenic diabetes insipidus. Whenever you think about nephrogenic diabetes insipidus in exam, you always think about lithium. Lithium-induced diabetes insipidus, very common. So lithium can damage the tubules and they can rise the creatinine and they can produce interstitial nephritis sort of scenario also. So question number 5, if you ask me, this is a real case. This is one of the cases where the patient was taking lithium. It's a lithium-induced diabetes insipidus, and the patient had a lithium-induced interstitial nephritis as well, because of tubular interstitial nephritis as well. Because of that, the patient's serum creatinine was also a little high. This is perfect example of a diabetes insipidus. The patient was not taking any loop diuretics. It was not an osmotic diuresis as well. To to note further, we need to know how to approach a polyuria versus a polydipsia. Suppose if the patient is having a polyuria, how you're going to approach a polyuria in the first place. As far as polyuria is concerned, first you need to know the definitions. Definition of polyuria states that if your urinary output is more than 3 liters per day, or if urinary output is more than 2 liters per meter square, this is useful for children, not for adults, or if it is more than 40 ml per kilogram per day. So this is what we refer to as a polyuria. And then you need to know what is the definition of a polydipsia. Polydipsia really means that the intake of water or any fluid is more than 6 liters per day, or if it is more than 100 ml per kilogram per day. So this is what we define as a polydipsia. There are very few conditions to produce polyuria and polydipsia, but in exam very commonly they will ask, how will you approach a polyuria versus polydipsia? Remember, there are two causes of polyuria basically. Whenever there is a polyuria, there are only two options are there. Either it could be a solute diuresis. Because of excessive solutes, you are producing more diuresis, or it could be a water diuresis. But trust my words, there are only two causes for solute diuresis. One is diabetes insipidus, another is psychogenic polydipsia. Psychogenic polydipsia. These are the only two causes that we really have for water diuresis, to be honest. So which means whatever may be the cause, all other causes will be something other than that. So which means everything else will be a solute diuresis. The only one condition, two conditions which produces water diuresis typically is the diabetes insipidus and psychogenic polydipsia, or we call it as a primary polydipsia or a functional polydipsia. You can call it in any way. So whenever you have a polyuria in your clinical practice, the next thing to look at is the serum sodium. So that's the most important thing. This is a multiple times asked question as well. If the serum sodium is increased, or serum sodium is decreased, or serum sodium is in the normal range. So these are three phenomena that you're going to encounter. Serum sodium increase means anything more than or equal to 145. I'll call it as increase. Even I can tell not 145, anything more than or equal to 143 itself, I'll be calling it as a high serum sodium. Reduced means I can call it as anything less than or equal to 138 in this setting, I'll be calling it as a reduced serum sodium. Anything in the range of 139 to 142, probably I can call it as a normal serum sodium. So this is a relativistic term, so don't get confused by that. So whenever the serum sodium is high and the patient is having a polyuria, so then check for the urine osmolality. In all these three situations, next step number 2 is to check the urine osmolality, whether they're passing a dilute urine or whether they're passing a concentrated urine. Let me rub off this just for making some space. So now we have the urine osmolality. In all these three things, the next step is to see the urine osmolality. So now I need to know whether the patient is passing a dilute urine or the patient is passing a concentrated urine. Suppose if the patient is passing a dilute urine, for example, less than 300 for that matters. So in the setting of hypernatremia and in the setting of passing a dilute urine, there can be only one possibility in the world, that is diabetes insipidus. If the patient is passing a concentrated urine more than 600, then probably I can be very sure that it's a solute diuresis. Solute diuresis can be due to many causes. It could be due to too much sodium intake, sodium chloride infusions, soda bicarbonate infusions, mannitol infusions. All this causes some kind of a solute and osmotic diuresis. So it could be even due to severe hyperglycemia, like diabetic ketosis or HONK purpose. So that also can result in polyuria. So some form of solute diuresis is going on in this situation. Suppose if it is in the range of 300 to 600, then I cannot be sure that it is solute or water diuresis. In this condition, it's better to look for a 24-hour urinary osmols. So usually this is not done. Most of the times it will be a straightforward. But if it's 300 to 600, then it's quite confusing. To be on the safer side, do a 24-hour urinary osmolar output. If the osmolar output is high, then I'll go for solute diuresis. If the osmolar output is low, then I'll go for diabetes insipidus. Solute means probably more than 1000, I'll call it as an increased osmolar output. If it's less than 900, I'll call it as a reduced osmolar output. Nevertheless, and this is how I'm going to evaluate a case of a polyuria with a high urinary sodium. There is a polyuria with low urinary sodium, which means sodium is less than 138. In this situation, once again, I see the urine osmolality. If the urine osmolality is less than 300 or urine osmolality is more than 600, so now if the urine osmolality is less than 300 in this situation, it's very clear I'm having a low sodium, which means a dilute blood with a dilute urine. Whenever I have a dilute blood and a dilute urine, I know very clearly this must be a psychogenic polydipsia. This must be a functional polydipsia. The patient is taking too much water, and that too much water is diluting the blood, and that is diluting the urine as well. So it's a psychogenic polydipsia. More than 600, definitely it's a solute diuresis. You have to evaluate for the cause of solute diuresis like mannitol and all this stuff. And if it's 300 to 600, you know what to do. You need to find out the urine osmolar output, like what we did before. So if you want, you can write. Otherwise, you need not write. Here, the urine osmolality is vital again. So whether I need to know whether it is less than 300, I'm passing a dilute urine, or I'm passing a concentrated urine, or if I'm passing a midway urine, like in the range of 300 to 600, which is confusing. Again, in that setting, I'll be again thinking about a like doing a urine 24-hour urinary osmolar output. So more than 600, it's definitely going to be a solute diuresis. There is no doubt about that. But here the problem is, since the sodium is normal, I don't know whether the blood is concentrated or dilute, but I know the patient is passing a dilute urine. Here I can surely tell that the patient is having some form of water diuresis, which means because of water that is going off in the urine, that's why the urine osmolality is low. But I cannot really tell whether it's a diabetes insipidus or a psychogenic polydipsia. If I'm having a hyponatremia of the dilute urine, I can be sure it's a psychogenic polydipsia. If I'm having a hypernatremia of the dilute urine, I can be sure it's a diabetes insipidus. But if the serum sodium is normal, then it's very difficult to tell that the patient is passing a dilute or a concentrated urine. If the patient is having a diabetes insipidus or a psychogenic polydipsia. In this situation, it's better that I do something called a water deprivation test to find out whether it's a psychogenic polydipsia or a diabetes insipidus. Again, if it's 300 to 600 means, I'm going to do a urine osmolar output. Based on that, I'll find out whether it's a solute or a water diuresis. But nevertheless, that's we know already. But better in this situation, it's better to see water deprivation test. Water deprivation test is otherwise referred to as a Miller-Moses test. So what do you mean by this Miller-Moses test? We ask the patient to be under water deprivation for some time. Then we check for the urine osmolality once again. We need to find out the curve. Remember, in water deprivation, you generally tend to find out a curve, which means you plot the serum osmolality in x-axis and plot the urine osmolality in y-axis. If you take the normal curve, normally the patients will be behaving something like this, which means as the serum osmolality keeps increasing, the urine osmolality also will keep on increasing. That is because of the ADH action. So when the ADH keeps on, as the serum osmolality increases, the osmoreceptors will trigger the ADH production. The more ADH it is, the more the urine is going to become concentrated. This is the curve that you're going to see. But in the setting of a diabetes insipidus, probably this curve will not be like this, and this curve will be more flat, which means the more the serum osmolality increases, the urine osmolality will not increase that much at all. So this is a typical curve of a diabetes insipidus. This is a typical curve of a normal patient. Usually psychogenic polydipsia patient will be falling somewhere in between. They might not have a normal curve like what we have, but psychogenic polydipsia patient definitely will have a much better response compared to that of the diabetes insipidus. You can actually, to understand, to a basic level of understanding, you can equate the normal patients with psychogenic polydipsia, but there are a lot of underlying problems are there in psychogenic polydipsia patients, especially if there is a chronic water diuresis going on. It might wash out the medullary interstitial hyperosmolality, and they may not respond to ADH like what you think. So that's different. So you don't want to confuse all those things. So psychogenic polydipsia are literally like normal, but not like normal patients, but still they have a very good response to water deprivation test. So this is the idea. So this is what we're going to pick up in water deprivation. And after water deprivation, we'll do something called a desmopressin test. So that also will help us understanding a lot of stuff. So let us plot what will happen in a water deprivation test. Let us start with the baseline urine osmolality. Baseline urine osmolality, what will happen in a baseline urine osmolality. Then we need to see the post-water deprivation. Post-water deprivation urine osmolality. And what will be the post-desmopressin urine osmolality in this situation. And I can also tell serum sodium if you want, and if we can also tell the MRI findings, MRI of the pituitary gland. So because sometimes in diabetes insipidus, it could be central and cranial diabetes insipidus, so pituitary might show some changes. So based on this, let us see the baseline urine osmolality. 3 disorders are there which we need to know. One is called central diabetes insipidus. Second one, we have something called nephrogenic diabetes insipidus. Second one, we have something called psychogenic polydipsia. Psychogenic polydipsia or a functional polydipsia. As far as the baseline urine osmolality is concerned, so when you think about all the three conditions will have low baseline urine osmolality, which means it will be usually less than 300, unless and it's a partial diabetes insipidus, which we'll be seeing subsequently. Usually it will be less than 300. Baseline in all this situation, it will be less than 300 only. I mean, in case if it's a complete DE, there is, but to complicate that, there is something called a partial DE also, which I'm not discussing now. In a complete diabetes insipidus, usually it will be less than 300 only. So now, after water deprivation, the only person who tends to improve their osmolality is the psychogenic polydipsia, because I told you the substantial improvement will happen in only psychogenic polydipsia patients in the urine osmolality. So after water deprivation, when you deprive the patient of water, your serum osmolality is going to increase. As the serum osmolality increases, the urine osmolality will increase in psychogenic polydipsia patient. Definitely, it will become more than 300. But in a complete diabetes insipidus, definitely it will be still low, less than 300 only. It will not improve in a complete diabetes insipidus. So after giving desmopressin, we know because in central means it's ADH deficiency. ADH is not coming from the pituitary. Nephrogenic means we are talking about ADH resistance. So since we are talking about a complete diabetes insipidus here, so to understand in a simple way, in central patients, now the urine osmolality will become more than 300 because desmopressin is going to mimic ADH action. So because it's deficient in central, once you give desmopressin, the urine osmolality will definitely increase in this situation. As far as psychogenic polydipsia is concerned, there will be no change in the urine osmolality because again, whatever response they want to achieve, they have achieved in the water deprivation time itself. So after giving desmopressin, it's not going to reach any additional response because during water deprivation, they've reached the peak urine osmolality. Even if you give desmopressin, that's not going to increase any urine osmolality any further. As far as the nephrogenic diabetes is concerned, it still won't change. What I mean by won't change is because it will be still less than 300 only. There will be no change. It will be still less than 300 only, which means, I mean, either you can write reduced or you can write, it will not change. Still, it will be less than 300 only. What I'm trying to tell is I'm going to compare this value with this value. I'm not comparing with the first value with the second value. I'm comparing with the post-water deprivation with the post-desmopressin value. Usually, psychogenic polydipsia patient and nephrogenic diabetes insipidus patients will not show any much change. Here, because they've already achieved during the water deprivation test, whatever they want to achieve, the maximum they achieved there. In nephrogenic diabetes insipidus patients, because of ADH resistance, there won't be any change. Already it is less than 300 only. Because of resistance, they won't increase any further. It still will be less than 300 only. Remember, it is quintessential to do in stepwise process. First, you need to do water deprivation. Then only you have to go for desmopressin test. If you do desmopressin first, then it will result in a big confusion. As far as the serum sodium is concerned, we know in diabetes insipidus, the serum sodium will be increased or it can be normal also. It's not like it's always increased. Whereas in psychogenic polydipsia, it will be usually decreased. It will be less than or equal to 137, as I told you, but it can be normal at times. So that's why. So whenever they give straightforward increased urinary sodium with low urine osmolality, it is diabetes insipidus for sure. Whenever they give low low serum sodium with dilute urine, that is low urine osmolality, it goes towards a psychogenic polydipsia. But when they give normal sodium, that is where the problem is, because now we have to do a water deprivation test in that perspective. Then as far as the MRI of the pituitary is concerned, in central diabetes insipidus, there will be abnormalities usually, especially there will be some infiltrative disorders. For example, you can see some pituitary infiltration causing a large pituitary, or you might see that absent bright spot, because that post-pituitary bright spot is very, very important area. Post-pituitary bright spot is a very normal thing. And if you don't have that, then you can think about probably a central diabetes insipidus. In this condition, usually the pituitary imaging will be literally normal in a nephrogenic diabetes insipidus and psychogenic polydipsia. Now, this table will be helping you to understand the complete forms of diabetes insipidus, but the problem is there are many partial forms of diabetes insipidus. That is where we get into trouble most of the times. Suppose if the patient is presenting with urine osmolality of less than 300, now I know you will be doing a water deprivation test. I'm seeing after water deprivation, if I'm having a urine osmolality of less than 300, surely I know this must be either a form of complete diabetes insipidus or it must be a nephrogenic form of diabetes insipidus, whether it's partial or this thing. So I can write two possibilities here. Either it could be a complete cranial diabetes insipidus, that is one possibility, or a complete central diabetes insipidus, one possibility. After water deprivation also there is no improvement, or any form of nephrogenic diabetes. Nephrogenic diabetes insipidus will behave like this only. If after water deprivation, if my urine osmolality becomes more than 600, surely in this setting, I'm dealing with the psychogenic polydipsia. Psychogenic polydipsia, but if it's in the range of 300 to 600, you cannot do anything in this setting. So when it is less than 300, if I'm going, I mean, if I want to differentiate the causes, then I'll be doing desmopressin test. I'll be giving a desmopressin test and I'll be seeing a post-desmopressin urine osmolality in this setting. I'll be seeing a post-desmopressin urine osmolality. So after giving desmopressin, if I see the urine osmolality, I need to see the change in the urine osmolality. How much change is happening in the urine osmolality is what I need to see. So the urine osmolality becomes more than 300 after giving desmopressin. That tells you definitely it is a complete cranial diabetes insipidus. So I can tell it's definitely a cranial diabetes insipidus. Or if my urine osmolality is not changing at all in the first place, it is still less than 300. I mean, still less than 300 in this setting, I'll be diagnosing a nephrogenic diabetes insipidus. The idea here is to tell that in the setting of nephrogenic diabetes insipidus, no matter what you do, whether it's partial or complete, you cannot tell. The urine osmolality will always remain less than 300. That's the take-home point here. Only cranial will produce urine osmolality of more than 300, irrespective of whether you do a water deprivation test or you do a desmopressin test. Doesn't matter. In nephrogenic diabetes insipidus, your urine osmolality will be less than 300 only. But the delta change might be helpful. How much it is changing compared to that of the post-water deprivation test. After giving desmopressin, if the change, how much the change in the urine osmolality is extremely negligible. If it is less than 15%, then it gets a very poor response. So it's a complete nephrogenic diabetes insipidus. If the change in the urine osmolality, if it's going to be somewhere around, we can talk about more than 300, I mean more than 15%, that is in the range of 15 to 45%. That's what the number that will be given in textbooks, 15 to 45%. There is some improvement is there. I mean, still it is less than 300 only, but improvement wise compared to the post-water deprivation, there is some improvement after giving desmopressin. Means you're talking about a partial nephrogenic diabetes insipidus. Not a complete, but some improvement is there. So we can talk about a partial nephrogenic diabetes insipidus. Now, cranial itself, you can divide into partial or central based on the, partial or complete based on the response. See the percentage change in the urine osmolality, delta change. If this delta change, percentage change in the urine osmolality is probably I can put here like this. If the delta change in the urine osmolality is happening by more than 50%, then it indicates a complete ADH deficiency. So it will be a complete central diabetes insipidus or a cranial diabetes insipidus. If the change in urine osmolality is less than 50% from the previous water deprivation value, then it will be a partial central diabetes insipidus. So this is how the textbooks will give. But it's it's quite obvious. So this is what is going to happen after water deprivation. So I can write cranial, so that's better. So less than 300 means it will be either cranial or nephrogenic. After based on desmopressin tests, you can actually split into cranial versus nephrogenic easily. But based on the percentage change of the urine osmolality compared to the post-water deprivation test, you can tell whether it's a cranial, complete cranial or partial cranial or complete nephrogenic or a partial nephrogenic forms of diabetes insipidus. So which is quite obvious in this particular example. If it's more than 600, straight away it's a psychogenic polydipsia only. So here I really need not do any desmopressin. Even if I give a desmopressin test, there won't be any change. I don't get any much change in the urine osmolality. No change in the urine osmolality. It will be the same. Why? Because whatever I wanted to achieve, that is more than 600, I've achieved during the water deprivation test itself. So after giving desmopressin, there is no point. So because I've achieved the ceiling effect here itself. Ceiling effect means the maximal effect I achieved during the water deprivation. So I'm not going to achieve any further here. But the most baddest as is this only. That is when you're getting 300 to 600. So this 300 to 600 after water deprivation is like a, it's like an endpoint. I mean, it's very difficult. You cannot do any desmopressin. Even if you do desmopressin, you're not going to achieve anything. So many studies have clearly proven that. So there are two possibilities here. The first possibility, I mean, of course, nephrogenic diabetes insipidus is ruled out. I told you nephrogenic diabetes insipidus, the osmolality can never reach more than 300. So that's ruled out completely. And it cannot be a complete, diabetes insipidus as well. In complete diabetes insipidus, even after your water deprivation, it will still be less than 300 only. So it cannot be a complete diabetes insipidus, I mean cranial diabetes insipidus. And nephrogenic diabetes insipidus is also ruled out, which means it rules out a complete CDI and it ruled out a nephrogenic diabetes insipidus as well. So only two possibilities are there. One is called a partial CDI and second one is a psychogenic polydipsia. Both are possible in this setting. So there is no test that can really differentiate. It's totally based on clinical evidence only. So see the question in exam properly. If they are giving some history of pituitary surgery, of course, it's a straightforward. You can think it's a central diabetes insipidus. Or if the patient is having some chronic headache, suggesting empty cella syndrome. So possible, or they could tell a pituitary adenoma. Or if the patient is having some systemic disorder, especially systemic disease means we are talking about a sarcoidosis, which is a very common cause of this kind of partial central diabetes insipidus. So there could be some evidences here. And look carefully for the MRI. If the bright spot sign is lost, then it could go towards a central diabetes insipidus. Or if it's a psychogenic polydipsia in that matters, patient will be having some psychiatric illness will be there. Patient is schizophrenic or depressive illness, long-standing depressive illness, or having some behavioral issues. Some psychiatric illness will be there. And most of the time, MRI will be completely normal, which means the pituitary will look absolutely normal in most of the settings. So look for this, or any drugs, history of psychiatric drugs like haloperidol. So that could tell you the possibility of patient having a psychogenic polydipsia. But other than that, the desmopressin test will not be useful if the post-water deprivation urine osmolality is in the range of 300 to 600. If the post-water deprivation urine osmolality is less than 300, these are the possibilities, which means it's straightforward. If the post-water deprivation urine osmolality is more than 600, straight away it's psychogenic polydipsia. There's no need to do anything else. If it's less than 300, then desmopressin test will help you to categorize whether the patient is having a partial variety or a complete variety. So that's the idea of a desmopressin test here. This is what you can do. And I told you the evaluation of hypernatremia, how to evaluate hypernatremia in exam, and how to evaluate a polyuria also. So if there is a polyuria, I told you when will you do a water deprivation test. Not all the cases will go for a water deprivation test. Only when you don't have a proper idea whether it's a diabetes insipidus or psychogenic polydipsia, and you want to differentiate between these disorders, then only you will go for a water deprivation test. That's called a Miller-Moses test. You're not going to go for a water deprivation test in all the patients of polyuria, only or polydipsia. Only few patients where you don't have proper idea, your confusion, normal serum sodium. Only in those patients you tend to do a water deprivation test, and subsequently you will be going ahead with the desmopressin test depending on the urine osmolality. Remember, if the urine osmolality is less than 300 after water deprivation, your desmopressin test will be very helpful. But if the urine osmolality is more than 300, that is in the range of 300 to 600 or more than 600, your desmopressin test will not be that helpful. So these are the final take-home points based on whatever I have told you till now. So this is how you approach a polyuria. This is how you approach a hypernatremia. Do you have any doubts in this? So this is case number 5. That's why I typically discussed on the case number 5. Do you have any doubt in this? So you understand. Okay, cool. That's nice. So everyone seems to understand this. So it's quite simple, not a very difficult thing at all. So, I mean, it might look a little different in textbooks when you study, but whatever I've told you, the same thing only they will have given in the textbooks also. So no need to worry about that. If you are predominantly concerned with hypernatremia, go for this algorithm. See whether it's dilute urine or concentrate urine. If it's dilute urine, most of the time we have hypernatremia at the dilute urine. Many times they are dealing with the diabetes insipidus. If it's concentrate urine, either it's a extrarenal water loss, or it could be possibly a sodium overload. So that is the final take-home point here. So you can use any of these algorithms in exam. But many times, dilute urine, hypernatremia in exam is equal to diabetes insipidus. That's what you need to know. Dilute urine, hypernatremia. diabetes insipidus. Possibilities are there, but still it is diabetes insipidus. Because psychogenic polydipsia cannot produce hypernatremia. They'll produce either hyponatremia or probably a normal sodium, but psychogenic polydipsia cannot produce hypernatremia. You should be very clear about that. Hypernatremia dilute urine exam is equal to always a diabetes insipidus only. Later on, you can use other testing to or other clues in exam to find out what is the cause of diabetes insipidus. So central means you will have some history, pituitary surgery, some intracranial infection, or some evidence of neurosurgery will be there. You can talk about a central diabetes insipidus. Nephrogenic means there will be drugs, lithium, demiclocycline. Some renal problem will be there for sure. So that's why here the clue what we have given in the question is this elevated serum creatinine, and that's should tell you that it's a nephrogenic diabetes insipidus. That's the complete diagnosis. Any other case you want to solve? You want case number 2 as well. Okay, but one more student is asking, before that, how will you treat hypernatremia? I mean, they are told like treatment of hypernatremia is there. So students are asking, how will you treat hypernatremia? Okay, we'll finish off because as we have discussed about hypernatremia, let us see how to treat hypernatremia as well. Remember, as well as most of the time hypernatremia is concerned, I told you it's primarily due to the water loss. That's what we're discussing. It's usually due to water loss only. That is the reason why you get a hypernatremia. I told you multiple times. So when you need a treatment, so the treatment usually will be based on the replacing that water loss. I mean, that is the most important thing. So we need to know what is the water deficit. Then only we can replace the sufficient water. How will you calculate water deficit? Water deficit can be calculated by sodium minus 140, which means sodium that is actually present right now, minus 140 divided by 140 multiplied by total body water. So this is something that is going to tell the water deficit. So now you know how to calculate the total body water. I think people who have attended my classes already will be knowing very easily the total body water in males means it is 60%. That is multiplied by 0.6 in total body weight will give an approximate amount of total body water. If it's a female, you can use 0.5 into body weight. So I'm writing total body water. 0.5 multiplied by body weight, which means 60% of the body weight and 50% of the body weight. This is the usual formula for adults, but if it's very elderly, then if it's a male, you can use 0.5 and it's a female, you can use 0.45 also. If it's elderly, like more than 60, 70 years, then in that setting, you can use a little less because elderly patients will have a reduced total body water compared to the adult patients. Children will have up to 70%. So if it's a young child, infant, 1 year, 6 months, then you can use 70%, 0.7 also. But standard formula is males, it is 0.6 multiplied body weight, and females it is 0.5 multiplied by body weight. So this is the formula that you need to know. So this is how you are going to calculate a free water deficit. So you need to replace that free water deficit. That's all. How much our water is deficient, you need to replace that free water deficit. And the second is how much change will happen in the serum sodium if you give 1 liter of a solution. So to replace water deficit, there are some solutions that you can use to replace water deficit. What are the solutions that we have? Typically what solutions you are going to use to replace water is hypotonic solutions. Of course, because this hypernatremia being a hypertonic condition, you need to use hypotonic solutions, which contain more free water. Typical hypotonic solutions are half NS, that is 0.445% NS, or you can use quarter NS, 1/3 NS. A lot of solutions are available, but typically in our routine practice, we use half NS, or you can prefer a dextrose 5 water. Dextrose 5 water, both are possible. Remember, sodium containing solution should be avoided in euvolemic and hypervolemic states. Typically, it is preferred in hypovolemic states. In hypovolemic states with hypernatremia, you can prefer a sodium containing solution. Half NS is fine. And second, dextrose 5 water you can prefer in patients who are hypervolemic or euvolemic state. So best example of euvolemic hypernatremia is diabetes insipidus. Diabetes insipidus is the classical example of a euvolemic hypernatremia. Fever is also one classic example of a euvolemic hypernatremia. But nevertheless, so if the patient is euvolemic, then you can use dextrose 5 water, or if the patient is hypervolemic, please avoid sodium containing solutions and give only dextrose 5 water, which contains no sodium at all. You give dextrose, it's like giving a pure water only. Remember, in that half NS On paper itself, it's hypotonic only. Everyone knows that. Half NS is basically hypotonic solution. Even, I mean, isotonic, the normal NS, that is 0.9% NaCl is isotonic. Naturally, half NS will be hypotonic. But if you take the dextrose 5 water on paper, it is basically an isotonic solution. It's not a hypotonic solution. But in vivo, when you give this dextrose 5 water, when you infuse this dextrose 5 water into the patient, it becomes hypotonic solution. Because the glucose will be rapidly metabolized. Once the glucose metabolized, they will leave behind only the free water. So in vivo, they'll become hypotonic. Once the glucose is metabolized, only water will be left. But on paper, if you take the osmolality, measure the osmolality, because the glucose is there, it will behave like a isotonic solution. That's one added advantage of dextrose 5 water. But one important point to notice, all these hypotonic solutions are contraindicated in patients with shock. Any patient with shock, you should never try to use hypotonic solutions, only isotonic solutions. Normal saline or ringed lactate. So that's the best solution in times of shock. Never use hypotonic solutions in times of shock. It will worsen the shock. And that's a very, very important contraindication. Fine. So now you know how to replace water. So how fast you will replace this water deficit is also a question. So if you want to replace this water deficit so fast, in the sense, depends. If it's acute, at once itself, you can replace the entire water deficit. Whatever water deficit is there, even if it's 3 liters, if it's an acute hypernatremia that is happening within 48 hours, then you can give at once, no problem. So even within 6 hours, within 1 day, at once means I'm talking within 24 hours, you can correct. All this water deficit you can correct within a day, no problem. But if it's a chronic hypernatremia happening for more than 48 hours, it's better to do very slowly. Typically, you can do by around approximately 6 to 12 milliequivalents per day. So slowly around 6 to 12 milliequivalents per day, you can do slowly if it's a chronic hypernatremia. But if it's an acute hypernatremia, you can correct everything. All the water deficit can be corrected within 1 single day. No problem. Nobody is going to ask you. But there is another formula that they will be expecting in exam. That is the change in the urine sodium. Change in the serum sodium with every 1 liter of an hypotonic solution. So for example, what will be the change in the serum sodium with 1 liter of some solution, some infusate that you are using, some solution you are using. For example, the formula tells that, the formula tells that sodium in the serum, which means the actual sodium in the serum minus sodium in the solution, that is the infusate that you are using, divided by total body water plus 1. So this is that formula particularly. This will tell you what will be the change in the serum sodium. So let me tell with an example, a simple example. Let us tell an 80 kilogram man who's having a serum sodium of probably 165. Due to some reason, he's having a serum sodium of 165, maybe due to too much of diuretic abuse in the ICU, possible, severe dehydration, severe water loss. So now how will you know, what is the amount of sodium that will change? Probably I'm using a 1 liter of dextrose 5 water. If I use 1 liter of dextrose 5 water or dextrose 5 solution, what will be the change in the serum sodium? So change in the serum sodium with 1 liter of dextrose 5 water will be, you can tell it in reverse also. Like for example, if the sodium in the infusate, what is the sodium in the infusate? It is 0, which means dextrose 5 does not contain any sodium. The actual sodium is 165 divided by total body water plus 1. Total body water here will be, I think, 48. In the sense like that's 48 liters will be the total body water, I feel, because 80 kilogram man means 80 multiplied by 0.6 is 48. So 48 plus 1 is equal to 49. So which will be 165 by 49 in this particular example. So if you calculate 165 by 49, I think you might get a grasp of an idea. So 165 divided by 49. I think it's 3.36 milliequivalents per liter. So which means this will be the change in the serum sodium if you give 1 liter of dextrose 5 water, which means if I give 1 liter of dextrose 5 water, my serum sodium will change from, initially it was 165, it will change to probably 161.7. So this will be the serum sodium if I infuse 1 liter of dextrose 5 water. Depending on how much you need, you can change. For example, I need to change 6 milliequivalents. I feel I need to change 6 milliequivalents of sodium, I can give 2 liters because 1 liter I know it will change 3.3. If I want to reduce the serum sodium in that particular day by probably 7 milliequivalents, then I'll be giving 2 liters of dextrose 5 water. If I give 2 liters of dextrose 5 water, according to this calculation, my serum sodium will come down to probably 158 because I need to reduce by 7. That is my target. So based on this formula also, you can find out how much free water that you need to correct how much sodium. So these are the two formulas that are there in reality to know how much free water that you have to give. So elderly male, it is 0.5. I told you already, yes. Elderly male, it's 0.5 multiplied by body weight, and in elderly females, it is 0.45 multiplied by body weight. Correct only. So we are talking about 80 kilogram man only, not 80-year man. 80 kilogram man only is an adult man. Okay. So now I think the hypernatremia as well as the polyuria as well as the treatment of hypernatremia must be perfect. Remember, in exam, usually hypernatremia questions will be based on diabetes insipidus. Usually. Hypernatremia, see the urine osmolality, dilute, go for diabetes insipidus. Correction in diabetes insipidus, because it's euvolemic, typically you will be using a dextrose 5 water for correction. How much dextrose 5 water to give? You can use any one of these formulas which I have told you. That's all. Do you understand case number 5? Is there any difficulty in understanding case number 5? So we can move on to the next question. Next case if you want. Do you understand or not? Yes, because if you have any doubt, I can solve now itself. That's why. So this, I mean, with this one case, we have diagnosed the we have completed the hypernatremia itself. So I don't think we need to complete. We need to push on any further hypernatremia in this setting. So then one student asked about case 2. So he wants to know case 2. So what's case 2 is telling? Case 2, sodium is low, hypernatremia is there, potassium is also low, 2.8, and chloride is 102, bicarbonate is 18, little bit of acidosis is there. Chloride is okay, but maybe a little elevated. Blood urine nitrogen 48, definitely elevated. It should be less than 20 or sometimes 15. So definitely elevated. Serum creatinine is 1.1 and urine sodium is less than 5. Very much low urinary sodium, and urine osmolality is 350, a little high. Patient is passing a concentrated urine. Okay, so how will you approach this case? So this case number 2, I can maybe write here. Case 2. So what are the findings I'm seeing in case number 2? I think I'm seeing hyponatremia, reduced serum sodium. And second, I'm seeing hypokalemia also, reduced serum potassium, because it's, I think, only 2.8 is there. Then I'm seeing metabolic acidosis, serum bicarbonate of only 18. But this metabolic acidosis, once I know it's a metabolic acidosis, whether it's a NAGMA or a HAGMA, that's the question. NAGMA or a HAGMA. So what is the, anion gap here? You need to tell that. It's a NAGMA or is it a HAGMA? NAGMA. So what is the anion gap here? What is the sodium? Sodium, I think it's 128. 128 minus, I think bicarbonate is 18 plus chloride is 102. I think here you will get 8 as the answer. So anion gap is less than 12. So typically it is a normal anion gap metabolic acidosis. So it's a NAGMA. So we are dealing with a NAGMA. But you don't have any urinary anion gap to tell what is the next situation. So I'll be having some cause of NAGMA. So, but I need to extrapolate and see what I'm having. So I'm having azotemia in the sense like my Bunn creatinine ratio is very high, which means Bunn is likely somewhere around, I think 48 here, divided by creatinine of 1.1. So which clearly tells the Bunn creatinine ratio is more than 20. Whenever Bunn creatinine ratio is more than 20, I'm dealing with a pre-renal AKE. We know that. I mean, even though we are not discussed, but it's very straightforward. The Bunn creatinine ratio is more than 20 means I'm dealing with the pre-renal AKE. And what are the causes of NAGMA? The NAGMA causes we know is URAT. So it could be ureteric diversion or a renal tubular acidosis or Addison disease or a diarrhea. Remember all these three causes except the ureterosigmoidostomy. Only ureteric diversion will result in euvolemic state, but renal tubular acidosis, Addison, diarrhea, GI causes, all these things can result in a hypovolemic state. All these three can result in all these three conditions can result in a hypovolemic state. Can produce, I'm not telling not always, all these three things can produce hypovolemic state and can result in a little high burn and probably even a high serum creatinine. But we know very well, Addison is a condition that produces hyperkalemia, and presence of hypokalemia, usually I'll not think about an Addison disease in this particular setting. So diarrhea, one possibility is there, which can definitely produce hypokalemia and hyponatremia. Both are possible in this setting. And as far as the renal tubular acidosis is concerned, so let me take another cause. RTA is there, renal tubular acidosis is concerned. Renal tubular acidosis, there are, type 4 anyway is ruled out because it's going to produce hyperkalemia. It could be either a type 2 renal tubular acidosis or probably a type 1 renal tubular acidosis, distal versus a proximal. But only one possibility I will think, usually because the bicarbonate is only 18 and the blood urea nitrogen is also a little high. So I'll be more concerning about a type 2 proximal RTA. Both are possible. I'm not telling no, but I'll be thinking about more of a type 2 proximal RTA rather than a type 1 distal RTA, because in type 1 distal RTA, I'll not be really expecting a bicarbonate of 18. So I told you, usually 12 to 20 bicarbonate, yesterday I told you, is usually happening in the setting of a type 2 proximal RTA. So nevertheless, both are possible. So we cannot tell concretely with this and all, that's only a probable finding, that's all. So either my diagnosis is an RTA versus a diarrhea. So if the patient has given a urinary anion gap, then that would have been one of the best ways to, find out. So if urinary anion is negative, I'd have talked about a diarrhea, or I need a proper history in that. So if I know a proper history, the patient is suffering from diarrhea, that's a straightforward entity. So I can tell it's a diarrhea. So these are the differential diagnoses here for the case 2. So I'll be thinking about more of a diarrhea in this setting rather than a renal tubular acidosis. Why not renal tubular acidosis? Because hypovolemia is extremely rare in a renal tubular acidosis compared to that of the diarrhea. So mostly this patient will be suffering from a diarrhea, according to my guess, because hypovolemia is extremely rare in the setting of a renal tubular acidosis. So I didn't use anything here. I didn't use anion gap. I didn't use I didn't use urinary anion gap. I didn't use any other extravagant things here. I just used the bicarbonate, anion gap, burn creatinine ratio, sodium, potassium, whatever is available. Based on this, I came to a conclusion that this patient is suffering from a diarrhea. Very likely. That's all. So that's why most of the time, just you need to assess. Just you need to see the differential diagnosis and just pick up what is the probable cause. Any doubt in this case? No, this is a straightforward case. See, hypovolemia can happen in RTA, but extremely rare. So if you really want to know how you classify hyponatremia, whenever you have a case of hyponatremia, if you want to approach through hyponatremia, also you can approach if you want, but that's very kind of a cumbersome kind of a process. Oh, Devi Krishna is asking how it is hypovolemic. Because of the burn creatinine ratio. Usually whenever I have a pre-renal AKI means it is due to hypoperfusion. This I can take it as evidence of hypovolemia with a history and with all the findings I have. Hypovolemia. I think you can get it now because he's asking how we are talking it's a hypovolemia. Okay. So hyponatremia can be approached in 2 different ways. One is, you can approach through hyponatremia also. You can see the serum osmolality. Basically, this is the first step. But this is a very this kind of a situation. But I don't really think that's needed. See the serum osmolality. The serum osmolality is increased or normal. Then we call it as a false hyponatremia. That's called a false hyponatremia. If the serum osmolality is decreased, then that's a sort of a true hyponatremia. This is what we refer to as a hyposmolar hyponatremia, the most commonest form of hyponatremia that we encounter in practice. Hyposmolar hyponatremia If it's hyposmolar, true type hyponatremia, then next step is to see the volume status. See the volume status of the patient, where the patient is hypovolemic, or the patient is euvolemic, or the patient is hypervolemic. Because it is very subjective, and even though there are some evidences like Bun creatinine ratio to tell hypovolemia versus hypervolemia, but still it is completely unreliable. That's why this kind of evaluation I don't like. It's better to always evaluate using all these parameters and the clinical picture, rather than just evaluating through some flowchart. These flowcharts are there just to understand about this particular disease. That's all. Apart from that, this is, I don't think, very valid in clinical practice, just based on hyponatremia evaluation. When the patient is having hypovolemia, then it is better to check the urinary sodium, because I know the patient is losing sodium somewhere. I need to know where the sodium is getting lost. It could be either urine sodium is decreased or urine sodium is increased. If urine sodium is less, for example, if it's less than 10, then I'll be probably thinking about extrarenal loss, because urinary sodium is not, less, so it's not losing through kidneys. Kidneys are trying to actually conserve. That's correct. It's an extrarenal loss. Probably I think about a gastrointestinal loss in this setting. The urine sodium is high, then it's a renal loss, which means renal loss means kidneys are doing some salt wasting. So this kind of renal salt wasting can happen in the setting of probably maybe mineralocorticoid deficiency, that is Addison disease, or any mineralocorticoid deficiency. Typically in primary adrenal insufficiency, this will happen. Or I can probably think about cerebral salt wasting syndrome, or any condition in the kidney that produces salt wasting. One example is cerebral salt wasting syndrome, which means it's something like salt wasting. That's what's happening in the kidney. But this is a very big clue in this particular question, I think, because we didn't notice that. So you'd have noticed that the urinary sodium is actually quite less. So it is less than 5. So since the urinary sodium is less than 5, so clearly I can tell that this patient is having extrarenal loss only. That itself tells again, this patient is definitely suffering from a diarrhea. This patient is not having a renal loss of sodium. So that's again a very important. So that just, correlate with each and every findings that's present in a case. It's very simple. So this patient is typically suffering from a extrarenal loss. So that's why I told you, I substantiate my statement. Even without knowing the sodium, I told you it must be a diarrhea only. As far as the euvolemic state is concerned, in euvolemia, overall total body sodium is normal. Then only you call it as euvolemia. So there's no point in seeing the urinary sodium. In this setting, I'll see the urine osmolality. I need to know whether the patient is passing concentrated urine or whether the patient is passing a dilute urine. The patient is passing a concentrated urine, more than 300. Typically in a euvolemic patient, it goes towards an SAADH. Typically it goes towards a syndrome of inappropriate antidiuretic hormone, syndrome of inappropriate antidiuresis. Or probably I can think about some endocrine problems like secondary adrenal insufficiency. Pure cortisol deficiency will produce only this kind of SAADH kind of a picture only. And mixed edema, hypothyroidism can produce this kind of a picture. These are 3 common conditions that you need to know for exam. Whenever the urine osmolality is less than 300, patient is passing a dilute urine, patient is having a hyponatremia, but euvolemic state, confusing. So usually this will be a psychogenic polydipsia. Psychogenic polydipsia. Or some form of water intoxication. Patient is taking too much of water. That's why the blood is getting dilute, urine is also getting dilute, and the patient is still remaining euvolemic because of good ADH access and good functioning kidney, good heart. In psychogenic polydipsia, the patient, whatever the patient drinks, they will be eliminating out without getting any volume overload state. Psychogenic polydipsia. Or probably there is in Western textbooks, they'll give something called a tea and toast diet. That's a low solute diet which can cause that. But usually in exam, this scenario means it's psychogenic polydipsia only. Whenever you have a hypervolemic state, again, you can see the urinary sodium because you need to know where the urine sodium is getting conserved. So urine sodium may be high or urine sodium may be low. If urine sodium is low, which means the kidneys are actually suffering to excrete this sodium, and you can assume that, which means they're retaining sodium from the kidneys. So which means any RAS hyperactivated states due to severe RAS activation producing hypervolemia. What are the, even I used to tell in my live, face-to-face classes, even in sleep, if they ask you what are the RAS hyperactivated states, you need to tell it is cirrhosis, then nephrotic syndrome, not kidney disease, nephrotic syndrome, and probably third one is CHF, congestive cardiac failure. These are the 3 conditions. Even in sleep, if they wake you up and ask what are the RAS hyperactivated states, you have to tell cirrhosis, nephrotic syndrome, and congestive cardiac failure. These are three quintessential conditions. Whenever the urine sodium is high, but still my, what is that? Sodium is, patient is having a hypervolemic state. If the urine sodium is high, still if the patient is having a hypervolemic state, you might be confused, like how is possible? Like this patient is losing more sodium in the urine, but having a hypervolemic state means the patient is having a low GFR. The kidneys are losing sodium. They will not be able to retain sodium because solute reabsorption is one of the important functions of the kidney. They are not able to do that, which means the tubules are damaged very badly, but still they are having hyperolemia. Means that's another problem. In the glomerulus itself, they're having a low GFR, typically in acute kidney injury or a CKD. AK or CKD. Remember, AK and CKD is typically not RAS hyperactivated state. There can be RAS hyperactivation, but they are not primarily due to RAS hyperactivation. The hyperolemia that you see in AK and CKD is due to low GFR, not typically due to the RAS hyperactivation. And at the same time, this high urinary sodium is a characteristic feature of a tubular damage. They cannot retain the sodium, which means they will pass very little urine only. But whatever urine they pass, they will have a high urinary sodium concentration because they cannot retain that sodium. So this is how you're going to, approach a hyponatremia in the first place. So this question can be approached in any form. So, but nevertheless, so you can even approach in the way I told you also. Even you can approach in the form of hyponatremia table also. You can approach in the form of the usual clinical expertise also. Whatever may be the case, you can explain. But still, this patient is definitely having extrarenal sodium loss. Because of that, they are having hyponatremia and hypokalemia. And at the same time, they're having a NAGMA, normal gap metabolic acidosis. They're having a hypolimic state, which is confirmed by prerenal AK, and the urinary sodium was very, very low, suggesting it's not a urinary cause of loss of sodium. It's not salt wasting, so it must be an extrarenal cause. So, of course, I'm thinking about a GI loss of sodium in this state, telling that the patient is likely suffering from a diarrhea. That's all. So, this is the case number 2. So, very, very simple, easy understanding of case number 2. And some points that they'll be asking with regards to treatment of hyponatremia. Treatment of hyponatremia again depends on whether the patient is hypovolemic, hypervolemic, or euvolemic. If the patient is hypovolemic in nature, having a high burn creatinine ratio, skin is visibly dry, mucous membranes are visibly dry. In the setting of hypovolemic hyponatremia, I'll be giving isotonic normal saline. This is the best solution that you can do. That is 0.9% NS. This is the best solution. Suppose if the patient is having a euvolemic hyponatremia, I'll be typically doing only fluid restriction. In the sense, water restriction is the key here. Fluid restriction is the main key. Plus or minus, I can use a Vaptan. Vaptan in the sense, this ADH antagonist, Vaptans, or we can tell V2 receptor antagonists, Tolvaptan, Conivaptan, and all these Vaptans can be used. Suppose the patient is hypervolemic, all I need is fluid restriction. That's what I need. Plus or minus, to small extent, I might be needing a loop diuretics to reduce the volume, because loop diuretics are the ones that produce reduce the volume status in this patient, because the patient is hypervolemic already. So this is the best. And few cases you can use Vaptans also. The best example is CHF. I think we have discussed that already. In congestive cardiac failure, if you take in cardiology, I would have told, like, if you have a congestive heart failure, CHF, then you can, if there is hyponatremia, then Vaptans are one of the options. I think you go back to the notes and see I would have given there. Vaptans can be used in CHF, but Vaptans cannot be used in cirrhosis because Vaptans are hepatotoxic. Tolvaptan, especially, very commonly used drug, highly hepatotoxic drug. So we don't use that in cirrhosis. We use in CHF. Even Vaptans are indicated in ADPKD, autosomal dominant polycystic kidney disease, but not in cirrhosis. Nephrotic syndrome, not much. CHF is the best example where you can use Vaptans if there is hyponatremia. Otherwise, you don't use in CHF. So these are the best options that you can use as far as hyponatremia is concerned. Remember, the rate of corrections they will ask. And again, that depends whether the patient is having some severe hyponatremia or a non-severe hyponatremia. Clinically speaking, you need to see the presentation. Presentation is severe hyponatremia, in the sense, like, if the serum sodium is less than 120, or if the patient is presenting with CNS manifestations, especially like seizures, coma. So this is a sign of a medical urgency. In this situation, the basic outline will not change, which means the outline is the same. The basic outline is the same. But here you have to give urgent 3% NaCl. Urgent 3% sodium chloride is mandatory here. you have to start immediately. If the patient is having severe manifestations, especially if the serum sodium is less than 120, or the patient is having, or the patient is having CNS manifestation like Caesar sarcoma. The patient is having non-severe manifestations, like only mild to moderate, non-severe, then usually your routine management is more than enough. Routine treatment. So I'm only telling for exams, but there are a lot of intricacies within this is there in real-time management. But as far as exams is concerned, routine means if the serum sodium is more than 120, or if the patient is not having any CNS manifestations, no CNS manifestations, then your routine management will have. Routine management means this is the routine management you're talking about. Clear? So usually whatever may be the type of management, whatever may be the type of management you do, they'll be definitely asking what is the rate of correction. They'll be asking you how fast you correct and how slow you correct. The rate of correction is very important. So for that, typically, 6 to 8 milliequivalents per liter is the standard that's given by every textbook. But they'll be telling you in acute hypernatremia, you can correct up to 10 milliequivalents per liter. And as far as chronic hypernatremia is concerned, you can correct up to 6 milliequivalents per liter per day. So this is the rate of correction, 10 and 6. But overall, whether acute is not there, chronic is not there, you can take some average of 8. 8 is supposed to be the standard most of the times. You can correct up to 8 per day. If you don't know whether it's acute or don't know whether it's chronic, you can go up to around 8 milliequivalents per day could be the ideal rate of correction. Beyond that, I don't think you need to correct. That's the idea. And typically, because of the current trend of questions, they might be asking you how fast or slow you need to give this 3% ACL. Remember, 3% ACL, you will give either 3 boluses max, 3 bolus of 100 ml, or till the symptoms are resolved. Which means symptoms are, the CNS symptoms are resolved. Caesar coma is getting better. So whichever is early. So what do you mean by the fact whichever is early? In the sense, for example, if the patient symptoms have been resolved with only 100 ml NS, 100 ml bolus, then with that itself you can stop. Need not give the second one. Or if you are given 3 boluses, still the patient has not recovered, then you have to stop anyways, whichever is early. That's what I'm trying to tell. So don't try to keep on giving 100 ml bolus after bolus. If the patient has recovered within 1 bolus itself, you stop there itself. No need to unnecessarily load with extra boluses. Even after giving 3 boluses of 100 ml 3% NS, the patient has not recovered, then which means most probably you are missing something else like stroke or some other problem is there. Suppose if you exceed this calculation like 10, 6, all this, if you exceed, what is the risk here? Everyone knows, isn't it? And don't tell central pontine myelinosis. I need the correct terminology. What is the risk here if you exceed? Yes, you're going to result in something called, the problem that you're going to face is, if you exceed, you will result in something called ODS, that is osmotic demyelination syndrome. Older name for this is central pontine myelinosis, because currently it's clearly proven that it's not only ponds you get demyelination, you get demyelination even in extrapontine centers. So that is ODS. But please understand the fact that it can even result in a locked-in state. Everyone knows what in locked-in state because you have attended CNS section. So even the patient might go for a locked-in kind of a state. So it's a very dreadful scenario. So don't do this. So don't do this kind of overcorrection. Remember, especially if you exceed that per day corrections, then there is a lot of issues. You should never exceed that per day corrections. Otherwise, you will enter with the ODS, osmotic demyelination state. Suppose if you accidentally exceed, is there any problem to avoid this kind of accidental thing? So in case of overcorrection, suppose if you have exceeded, accidentally, so without your knowledge you have exceeded, then you can use desmopressin. Desmopressin can be tried because desmopressin is an ADH kind of an analog. So they reabsorb more water. So once they reabsorb more water, the sodium will come back down again. So at any cost, you should not exceed. In case if you accidentally exceed, and if you have accidentally overcorrected the sodium by some means, and if you came to know that, give desmopressin plus or minus. You can use dextrose 5 water to reduce the sodium back to the target range, whatever you need. Usually this accidental overcorrection is highly likely if the patient is having a hypovolemic hyponatremia. Overcorrection is more likely if you are having a hypovolemic hyponatremia, because in hypovolemic hyponatremia, there will be strong, suppose if the patient is having a hypovolemic hyponatremia, because of hypovolemia, there will be severe RAS activation. This RAS will have too much of ADH action. So now you suddenly correct the volume to euvolemic state. Suddenly correct the volume to euvolemic state. Now the RAS will go and the ADH action will go and the sodium suddenly picks up because ADH is no longer acting. So because the ADH is no longer acting, the sodium tends to rise suddenly. That's why whenever you're having a hypovolemic hyponatremia, you have to be very careful, especially when you're treating with a normal saline. There is a lot of possibility that the sodium might improve much faster, because the moment you make the patient euvolemic, the patient will go for loss of ADH action. Once the ADH action is lost, your sodium will become normalized very rapidly. So coupled with that, if you are giving sodium in the solution, that in the form of your sodium chloride solutions, that will also add up and the sodium will start rising very fast. So this kind of overcorrection is very common in hypovolemic hyponatremic states, but nevertheless, you need to know all these things. So remember, usually currently indication of 3% ACL is only one thing. In fact, many indications are there, but as far as hyponatremia is concerned, the only indication is very severe hyponatremia like sodium less than 120 or the possible presence of CNS manifestation. These are the only two indications where you need to give urgent 3% ACL as far as hyponatremia is concerned. But if the patient is having other problems like intracranial space occupying lesion or stroke is there, that is causing edema, in that setting you can give continuous 3% ACL for a long time. That is for reducing the ICP purpose. Here also you're giving for reducing ICP, but as far as hyponatremia is concerned, these are the usual indications for giving 3% in ACL. Apart from that, we don't have indication in hyponatremia treatment. So usually your exam question will be dependent on how fast you should correct. That's very important. If you don't, in acute or chronic, in acute they would have given us 8 to 12. In chronic they would have given us 4 to 6. This is what they would have given in textbooks. Literally exact number that are given in textbook is 8 to 12 and 4 to 6. But any textbook will tell the lesser is better always. The lesser you correct, better it is, because this is some complication that you can actually avoid, this kind of ODS. So that is why always they will tell lesser is better. So that is the reason why many textbooks will give different answers, because it's based on individual experience. So but textbooks will tell in acute you can correct up to 8 to 12, in chronic you can correct up to 4 to 6. So standard answer, if you clearly know if it's acute, you can go up to 10. In chronic, you can go up to 6. If you don't have anything, go for answer 8. That's better. If you don't know whether it's acute or chronic, go for answer 8 milliequivalents per day. Most of the times it will be correct. So exceeding ODS, that's a common question. And in case of accidental overcorrection, give desmopressin. That's also a common question in exam. And how much bolus you have to give? Maximum of 3 bolus. That's also a question. 100 ml, which means 300 ml is the maximum. Or if you give 150 ml, then 2 bolus only, which means 300 ml should be the maximum of 3% ACL in acute severe hyponatremia. So till how long you can give, or you can give till symptoms are resolved. Indications for 3% ACL, either less than 120 or severe CNS manifestations. That's all. So standard treatment, hypovolemic, normal saline, euvolemic, fluid restriction alone plus or minus Vaptans. In hypervolemic, then you can give fluid restriction, loop diuretics to correct the volume, and Vaptans in case the patient is having CHF. Remember, if they ask you in euvolemic hyponatremia whether you will give Vaptans or not, remember, Vaptans can be given if the urine osmolality is very high. If the urine osmolality is very low, they don't work. Because already the urine osmolality is very low, then what you are going to achieve by giving Vaptans? Which means already they are passing dilute urine. Vaptans are going to cause dilute urine only, because Vaptans block the ADH action. Once you block the ADH action, it will result in a diabetes insipidus kind of a scenario where you are going to pass dilute urine. Idea of giving Vaptans is to make the patient pass dilute urine so that you want to concentrate the blood, increasing the sodium. So already if the patient is passing a dilute urine in psychogenic polydipsia, what is the point in giving Vaptans? Already they are passing dilute urine. So giving Vaptans will not have any effect here. So that is why Vaptans can be tried if the patient is having a high urine osmolality, especially in the setting of a SAADH. Clear? SAADH has so many causes. So many causes in the real practice. Anything and everything can cause SAADH. But nevertheless, you have to know some cause of SADH in exam, which will be very useful for you. So this is how you evaluate case number 2, where we have evaluated in the form of NAGMA and with other parameters we have told. And at the same time, we evaluated using hyponatremia flowchart also. So this is how we evaluate a second case. Any other case you want me to answer? Any other case you want me to answer? Case number 1 and 11. Okay. So case number 1, I think it's much easier. So let me rub this off because we have discussed all these things. Let me discuss case number 1 and 11. And Harshitam wants case number 15 as well. Okay. So for as far as case number 1 is concerned, the patient is having hyponatremia. Patient is having, okay, I don't think it's hypokalemia. Patient is having a normal potassium. And the patient is having a little low chloride. That's okay. But a normal bicarbonate, no acidosis, no alkalosis, according to the particular thing. And patient is having a Bunn-Creatinine ratio normal, no problem. So I can rub this also. So this all is not having any issue at all. And the patient is having a low serum osmolality. Definitely this is low, less than 300. Usually I take it as low. Anything less than 285, it's definitely low. And urine sodium is very, very high. So 90 is too high, according to me. And anything less than 40, I'll take it as okay. More than 40, it's definitely high. And urine potassium is okay, 75, fine. Depending on that, depends on the daily sodium intake, daily potassium intake, and urine osmolality is extremely high, more than 600 in fact here. So they're not given the urine output. So based on the available data, let us try to evaluate what's happening here. So this, I don't think it's a case of acidosis or something else, acid-based problem. This is basically a case of hyponatremia. So if you want to know case number 1, so this is basically a case of hyponatremia where the patient is having, I think, sodium of 116. It's a little severe hyponatremia. Sodium is 116. And still, I cannot rule out an acid-base disorder. So it's better to do a anion gap to be sure that it's a normal anion gap. So what's the anion gap here? 116 minus 24 plus 85. 116 minus 24 plus 85. I think it is normal anion gap. 109.7. 7 is the anion gap. No, you should not call NAGMA. Remember, only if it's a high anion gap, then you can call HAGMA. If the bicarbonate is normal, that's why I clearly told you if the patient's bicarbonate is normal, I should not call it as a NAGMA here. If the bicarbonate is normal, you cannot call it as a NAGMA. This is not a NAGMA. Just to make sure that the patient is not having high anion gap, I did this. But don't call it as a NAGMA. This is a normal anion gap. So I'm going to rub this off. No problem at all there. So then low serum sodium with low serum osmolality. Low serum osmolality means surely it's a hypoosmolar hyponatremia. I'm very sure about that. Then next is seeing the urinary sodium. Because Bunn-Creatinine ratio is typically normal, I don't really think it's a hypovolemic hyponatremia also. Usually in hypovolemia, the Bunn-Creatinine ratio will be a little high. So it's not telling anything. So it's very likely to be a euvolemic hyponatremia. So then I can see the serum osmolality and urine sodium. I'm having an increased serum sodium and increased urine osmolality. This is what I'm seeing. Sorry, increased urine sodium and increased urine osmolality. So as per our understanding, you're having an increased urine sodium, and because of that, it means it's an increased urine osmolality. So in this setting, I'll be thinking more likely an SADH kind of a process. Okay, so that's the final diagnosis here. If you want to know about the case number 1, this is basically an SADH, that's all. Or it could be secondary adrenal insufficiency, or it could be mixed edema as well, but I need other data. With this data, I can conclude that this patient is mimicking a SADH kind of a picture. Because I'll be going towards, where is that hyponatremia table? In hyponatremia flowchart, I know it's a hypoosmolar hyponatremia, volume status likely euvolemic because that patient is having a normal Bunn-Creatinine ratio. Now the urine sodium is very high. If the urine sodium is very high, means I can conclude urine osmolality also should be very high. So very likely my diagnosis in that particular setting is SADH. So that's a very straightforward case. This could be some cause of SADH, like malignancy, infection, anything could be the case. I need to find out. Then they need case number 11. Okay, let us see what is happening in the setting of case number 11. Case number 11, you have normal urinary sodium. So no, I mean serum sodium, no problem. And the patient is having a hypokalemia. Okay. Then patient is having little high chloride. I think 114 is definitely high. Definitely bicarbonate is low. And Bundt creatinine is okay. No problem at all. In Bundt creatinine ratios, I'm not going to consider that as very important now. And urinary sodium is okay. So that's not important here. And urinary potassium is definitely high. So urinary potassium is surely high because in the setting of hypokalemia, in hypokalemia, the kidneys should not excrete potassium. So that's the homeostasis. If the kidneys are excreting potassium in the setting of hypokalemia, I'll be thinking about something is wrong. So, I mean, kidneys should conserve potassium in hypokalemia. That's the homeostasis. I told you yesterday. If you drink less water, pee less water. If you drink less sodium, pee less sodium. If you drink more potassium, pee more potassium. If you drink less potassium, pee less potassium. That's the homeostasis. Here, the patient is having low potassium in the blood, but 45 is definitely high. Anything more than 15 is high. So this is a definitely high potassium that is there. And urinary chloride, okay, 32. So urinary pH is 6.5. I think it's a very good case and it's easy to diagnose as well. Not a difficult thing at all. So primarily I'm dealing with a case of hypokalemia actually here. Either you can approach through hypokalemia or you can approach through your acid-base disorder also. So let us first see the usual routine way. So where we have understood our acid-base understanding. As far as the acid-base understanding, this patient is having an acidosis. Bicarbonate is low. That is 16. Now tell me it is a NAGMA or a HAGMA. What is the reason for this acidosis? Normal hand-gap metabolic acidosis or a high hand-gap metabolic acidosis? Yeah, this is basically an NAGMA. So why this is a NAGMA in first place? Because this patient is having a sodium of 139 minus 114 plus 16. So it means it's 130. So anion gap is 9. So this patient is definitely having a normal gap metabolic acidosis. So this bicarbonate of 16 is basically a NAGMA. So once you know this patient is having a NAGMA, you have only few causes. One is called a URAD. Clear? So in this, all these can have a euvolemic state, which means hypovolemia, then fine. You can think about a diarrhea, but and Addison disease, all this can have a euvolemic state. All this can produce a euvolemia. So which means it's not like necessarily everything should have hypovolemia or few things should have hypovolemia. So now confusion starts. Now let us use the other values. Now I am having a hypokalemia. So there are only two things that are possible here that can produce hypokalemia. One is my renal tubular acidosis. Second is diarrhea. In renal tubular acidosis, it could be a type 1 or a type 2, or diarrhea, it could be one of the possibility. But I think I know the urinary chloride, urine sodium, and urine potassium as well. So now to differentiate, I need to know it's the urinary anion gap. So what is the urinary anion gap here? So they have given the urinary chloride also, I think. Urinary chloride is also given in this example. So urinary chloride is 32 and urinary potassium is 45. Urinary potassium is 45 and urinary sodium is 20. So somebody tell me the urinary anion gap. I mean, if you are having this already. So urine sodium is 20 plus urinary potassium is 45 minus it is 32. So urinary anion gap is positive or negative? That's the question. So 65 minus 32, it is 33. So it is a positive urinary anion gap. If it's a positive urinary anion gap, you think about GIT cause or a renal cause. Think about a GIT cause or a renal cause here. Definitely I'm thinking about a renal cause here. It could be either a type 1 or a type 2 renal tubular acidosis. So now because it's positive, now my diagnosis is type 1 versus type 2 renal tubular acidosis. So seeing the bicarbonate, it looks like probably it's a type 2 RTA because it is 10, 12 to 20. Usually I think of a proximal RTA that is type 2. But on the other hand, that's not the confirmatory point. I need to see the urinary pH. See the urinary pH. Urinary pH is definitely alkaline here. Urinary pH they have given it is more than 5.3. So in the presence of acidosis, if my urinary pH is alkaline 6.5, which diagnose you will choose. You will choose a type 1 RTA or a type 2 RTA, which you will choose. In the presence of acidosis, if you have a alkaline urine, pH of 6.5, urinary pH. Of course, I will be choosing a type 1 distal RTA, because yesterday itself we saw very clearly that in the presence of acidic blood, if you have an alkaline urine, there is only one possibility in the exam, that is distal renal tubular acidosis. Proximal may have an alkaline or acidic urine, but as far as proximal is concerned, in the presence of acidosis, that urine will become acidic because the active H+ secretion in the distal nephron. But in the presence of blood acidosis, if you have an alkaline urine, that's very typical of a distal renal tubular acidosis. So that's one important entity. So that's a distal RTA. For sure, it's a distal RTA, no doubt about that. But the idea is many students will be asking how to approach in terms of hypokalemia. Using hypokalemia, how can I approach? Yes, you can approach using hypokalemia perspective also. From the perspective of hypokalemia, you can do. But again, it's like touching like this. Most of the time, it will be straightforward. If you analyze all the things, it will be straightforward. Siddha is asking, above cause may be due to over usage of diuretics. But if it's a over usage of diuretics, I should have a high urinary sodium. That's one thing. I should have very high urinary sodium, and urinary chloride also will be high. And diuresis usually will produce alkalosis, not acidosis. If you talk about a loop diuretic or a thiazide diuretic, the basic effect that they're going to cause is alkalosis and not acidosis. I don't think bicarbonate will be 16 in that setting if it's overuse of diuretics. So that clearly tells you that it's not due to diuretics. It must be due to something else only. It's an acidosis here. Fine. I think that will solve the question. So you can, achieve the diagnosis using hypokalemia also. Suppose if the patient is having hypokalemia in this perspective, you can think about doing a urinary, you need to know where the potassium is getting lost, whether it's a urinary loss or whether it's a renal loss. That's the first idea. So I need to do something called a urinary potassium creatinine ratio. This is well available. Or you can do a spot urinary potassium also, but that's not very reliable. If the urinary potassium creatinine ratio is less than 13, or if it's more than 13, or if you want to do a spot one, spot value, it's completely unreliable. But in exam, if the examiner gives a very primitive kind of a question, giving a spot potassium, then 15 might be a cutoff. Less than 15 means you can come through this side. More than 15 means you can go through that side. So depending on that again. Clear? If they want to give a spot potassium, then 15 might be the cutoff. So if the KCR is less than 13, or if the KCR is more than 13, KCR less than 13 means definitely I'm having an extra renal loss. It's definitely not a renal loss for sure. If the KCR is more than 13, which means the potassium is getting lost in the kidneys only. So it's definitely a renal loss of potassium. So whenever the patient is having a extra renal loss, see the acid-base status, see the ABG status. So I'm going to deal with either an acidosis, or I can deal with an alkalosis. Or normal ABG means it's like something like profuse sweating and physiological cause only. If it's acidosis, typically in this particular setting, the patient is having hypokalemia and having a extra renal loss, acidosis. In this particular setting, I'll be thinking about probably diarrhea. Diarrhea can well cause acidosis. We all know that diarrhea can cause acidosis. Or if it's alkalosis, then in this setting, I'll be thinking about a diuretics. Clear? So that's what happens. So, diuretic in the sense like remote diuretic use in the past. So maybe like 2 days, 3 days back. So that's why they're having a low potassium in the urine, but probably having alkalosis in the blood. So this evidence of alkalosis tells you that the patient is probably using a diuresis. Very rarely even diabetic ketoacidosis can do that. DK also can have, but DK mostly will write there, no problem. As far as the renal cause is concerned, renal loss is concerned, the KCR is more than 13, then the most important next step is to see the BP, blood pressure. In the blood pressure, whether you have to see whether it's hypertension or the patient is having normotension or a low BP. If it's hypertension, usually hypertension with hypokalemia usually go towards that hyperaldosteronism. So next step is to see the aldosterone-renin ratio. This is a very common question in exam. If they ask you hypertension with hypokalemia, what you will do next? Go for the aldosterone-renin ratio. Based on that, you will divide into whether it's a primary hyperaldo or secondary hyperaldo or a non-aldosterone mineralocorticoid excess, the details of which we have discussed yesterday itself, so I'm not going to discuss again. Based on that, you can divide. Suppose if the renal loss, with the renal loss, if the BP is normal or the BP is low, then again see the acid-base status. See where the patient is having a metabolic acidosis or a metabolic alkalosis. The patient is having metabolic acidosis, then it could be a diabetic ketoacidosis, which is one very important cause of a renal loss of potassium. And at the same time, patient might be a renal tubular acidosis, which is also a very important cause of renal loss of potassium. Or the patient might be using some drugs, like for example, toluene, astazolamide. This can also result in development of a type 1 RTA kind of a picture, or even amphotericin B. So some drugs are there. You think about that in that particular setting. Suppose the patient is having alkalosis, then in this setting, patient is using active diuretics. Either two possibilities are there. Actively, they are using diuretics. That's why they are having alkalosis, and active renal loss of potassium is there. Or probably they are dealing with a vomiting. I told you yesterday multiple times in yesterday's lecture that vomiting is a renal loss of potassium. Many times we have talked about that. So when you want to differentiate these two, you need to know the urinary chloride. Urinary chloride will help. If you do a urinary chloride, if urinary chloride is going to be less than 10, so very low urinary chloride, so which means it's a chloride responsive, which means I'm talking about a vomiting here. I'm dealing about a vomiting, so which means there is complete chloride depletion. Because of the chloride depletion, my chloride in the blood is lost. Because of that, my urinary chloride is extremely less. Or if the urinary chloride is more than 20, then probably in this setting, I'll be thinking about diuretic use. Current diuretic use or diuretic abuse. Or second thing is like I can think about the congenital syndromes, Bartter syndrome or Gitelman syndrome in this perspective. That's what I'm going to deal with. Bartter or Gitelman syndrome. So this is how I'm going to evaluate a case of hypokalemia, depending on what is happening here. So in this particular patient, it's actually acidosis that is happening. So it's not alkalosis. I don't know the urine protein creatinine ratio, but still I know the patient is having basically acidosis, not alkalosis. That is what happening in this patient. So because of that, I can rule out all the alkalotic cause, which means diuresis is completely gone. That is what Siddharth was asking. So what about diuretics? So because the patient is having acidosis, I cannot talk about diuresis or vomiting here. So because acidosis means this should be the usual possibility. And we know in my case, I'm having a normal NGAP metabolic acidosis. If it's a normal NGAP metabolic acidosis, it must be either renal tubular acidosis or it must be a diarrhea. These are the two things that cause normal NGAP. Because DK cause high NGAP metabolic acidosis only. Because I don't have any history of drugs, I'll be thinking about a renal tubular acidosis in this setting or a diarrhea. And how I differentiated based on the urinary NGAP. Because my urinary NGAP was positive, I was thinking about a renal tubular acidosis. And after that, next step, I saw the urinary pH. Because it was alkaline, I thought about a type 1 distal RTA, then a type 2 proximal RTA. So, you can go by the algorithm also, or typically you can go by, like your basic clinical expertise also. Most of the times, even the algorithms are existing in clinical practice, but I don't really go by algorithms. We can say it by directly seeing urinary pH. No, actually not. Suppose what if the patient is having bicarbonate of 31 and the urinary pH is 6.5. So how can you tell this is a, Pranav is asking, directly by seeing urinary pH you can tell distal RTA. That might be a shortcut in exams, but if a bicarbonate is 31 without seeing that, how can you tell it is a renal tubular acidosis? So not possible. With the bicarbonate 31, I'll expect alkaline urine only, of course. It all depends. Again, so you cannot really tell directly by seeing urinary pH in that setting. So we need to say the acid-base status in the first place. That's the idea. I think any doubts in case number 11? I think somebody asked case number 15 also. So this is only for case discussion. So case number 15, someone has asked. So what we are seeing in case number 15, let us see. We are seeing a little bit of, I think, hypernatremia. Small amount of hypernatremia is there, 144. I think it's a little high. Potassium, okay. Chloride, okay. Bicarbonate is a little less. Okay, let me round. Later on, I will see. Okay, little less, but fine. What about BUN creatinine ratio? Definitely BUN and creatinine both are elevated. Burn is 51, creatinine is 2.8. Surely something is happening here. So that's surely wrong. And serum osmolality 355, a little high. We can note that as well. And more than 300. Urine sodium is 50, a little elevated. But I mean, in the context of high sodium, I mean, hypernatremia, 50 might be okay according to me. And again, it's relative only. And I'm having a urinary potassium of 31. I mean, in the context of normal urinary potassium, that 31 may be acceptable. That is why, like whenever you see a value in your practice, you should always compare with what you're having with other things. If the normal potassium, then 31, I will take it as a okay value because it indicates a dietary potassium intake. That's all. That is not a high potassium or a low potassium. But in the setting of hypokalemia, if I see 31, then that's definitely wrong because that's too much. Because kidney should not excrete that much of potassium in hypokalemia. It's all relative. And urinary chloride is 30. Okay, not a problem. And urinary osmolality is 95. Okay, all right. Then I'm having a 6 liter urine output, urine volume that typically tells you it's a polyuria. Anything more than 3 liter is polyuria. And they have clearly told the calcium is 12.6. So clearly it tells you if the calcium is 12.6 means there is a hypercalcemia also. That settles the debate. It is hypercalcemia induced problem only, in crisis only. So let us see the algorithm. So how to evaluate a polyuria? We have seen already. So whenever patient is having a polyuria, where is that? Polyuria. I need to see the serum sodium. Here the serum sodium is increased or serum sodium is decreased. Tell me now. So what is the serum sodium? So I know a patient is having a polyuria. So what is the serum sodium here? According to this chart, it is increased or decreased or it is normal. It's 144. So definitely it is increased. So what is the urine osmolality? I mean, as an overall view, it is, what is the urine osmolality? It is somewhere around our range. What is that? What is the urine osmolality? It is decreased or increased? Urine osmolality is decreased in this particular example. Yes. So because the urine osmolality is decreased and the serum sodium is high, and we are establishing a case of polyuria, likely I'm dealing with the diabetes insipidus. All right. So what kind of diabetes insipidus it should be? I mean, see the values and tell what kind of diabetes insipidus. Basically. It's nephrogenic or central. See the values and tell. Yes, of course. Of course, this patient is having nephrogenic because I'm having a high creatinine and high blood urea nitrogen. So this is likely to be a nephrogenic diabetes insipidus. Actually, I'm dealing with the polyuria with the high sodium, with a probably low urine osmolality, because with this kind of high sodium, I don't expect like urine sodium should be 50. It should be high. It is low. So probably it is considered to be a low urine osmolality. And at the same time, so this patient is surely having a diabetes insipidus, and this patient is likely suffering from a nephrogenic diabetes insipidus. Why nephrogenic diabetes insipidus? It is due to hypercalcemia. Hypercalcemia, yesterday, if you think multiple times I told you, it's a very big toxin to the distal area of the nephron. So this calcium is the main reason here. So now if you assume, if you want to dig further and you want to know what is the reason for this high calcium, you see the PTH. PTH is only 0.6 here. What is in 0.4 here? I mean, nobody knows the normal PTH, whoever is listening right now. Normal PTH is somewhere around 15 to 60. That's a normal PTH, which means it's a clearly suppressed PTH. I'm having hypercalcemia that is suppressing the PTH, which means this is a secondary hypoparathyroidism. Secondary hypoparathyroidism, which means the calcium is the one that is suppressing, which means the calcium should be the primary problem that is actually reflexly suppressing the PTH. So which means PTH is not the cause. Then what should be the cause? You don't believe? After evaluation, I mean, this patient had a BP of 200, 140. And after evaluation of this patient, we found this patient had a 7 centimeter big pheochromocytoma in the left adrenal gland. And because of the pheochromocytoma is known to produce that PTH-related peptide. Because the PTH-related peptide that is producing in excess as a result of paraneoplastic syndrome, they are having hypercalcemia. Because of hypercalcemia, they are having nephrogenic diabetes insipidus. And I can write here. Okay. Because of hyperparathyroidism, they're having, because of hypercalcemia, they're having nephrogenic diabetes insipidus. Because of this hypercalcemia, the PTH is basically suppressed. And in a CT abdomen, we found out 7 centimeter big pheochromocytoma in this patient. This is another case. And this is an excellent case again. This is case number 15. It's quite easy. Any other case you want me to explain and help? Any other case you want? We discussed almost every case, I think. Whatever case you asked, I discussed. Any other case you feel difficult so that you want me to discuss? No. If you really want me to move on, I'll move on. Or if you want one more case to discuss, I'll discuss. You have some time. Case number 7. Yaman is asking case number 7. So let us see what happens I think that must be a very simple one. Case number 7. So in case number 7, you have sodium okay, potassium borderline. I don't call it as normal potassium, but little high. So I can remark the sodium, which is more than 140, maybe borderline high. Potassium 5, chloride okay. Definitely this patient is having acidosis, and Bun creatinine ratio is seriously elevated. 58, 3.6, blood glucose is 520, and arterial PCO2 is 31. So having some sort of low CO2 that is going on. So what I need to find out is, first of all, I need to write as per our understanding. So I think I can write here. So I'll rub this off. So this patient is having definitely an acidosis. So bicarbonate of 17 is there. Surely acidosis is there. So what is the acidosis? Here it's high ANGAP metabolic acidosis or a normal ANGAP metabolic acidosis? HAGMA or NAGMA that you're dealing with in this particular example? HAGMA. If so, what is ANGAP? You have sodium of 141 minus chloride of 102 plus 17 is equal to, I think, 20. 20 is ANGAP. So definitely this patient is having a HAGMA without a doubt. If the patient is having HAGMA, then of course next step will be to see the delta-delta ratio. So what is the delta-delta ratio here? So I think delta-delta ratio means ANGAP minus 12 by 24 by minus bicarbonate. ANGAP here is 20 minus 12 divided by 24 minus bicarbonate. Here it is 17. So minus 20 minus 12, right? 20 or 30, man? Correct only, no? ANGAP is 20. Okay. So 20 minus 12 divided by 24 minus 17. So this patient is probably having 8 divided by 7 is equal to 1 to 2. So, okay, very likely to have a uncomplicated HAGMA only. So there is nothing like they're having an associated NAGMA or associated metabolic alkalosis. This patient is likely to have a uncomplicated. I think I'm doing something wrong here in the calculation. So let me write again. So 112 plus 17 is 119, I guess. I think here is where I did a mistake. I think it's 119, 141 minus 119. So I think I'll be getting 22, I guess. 22. So I think that will again not make a difference because I thought something I made wrong. Okay, anyway, the difference will not be there, even it's 22. So ANGAP minus 12 divided by 24 minus bicarbonate, that is 17, is equal to 10 divided by 7 is equal to, again, you will get a range of somewhere in 1 to 2 only, which means it's an uncomplicated high ANGAP metabolic acidosis. There is no associated metabolic alkalosis, to be precise, in this particular example. So it's a HUGMA. We know that. And we need to know whether it's a correct compensation or an inappropriate compensation. For that, I need to see the PCO2. PCO2 is 31 in this patient. So PCO2 is decreased as well as bicarbonate is decreased, and arrows are moving in the same direction. If arrows are moving in the same direction, I need to find out whether this is correct or not. Let me see the Winters formula, whether it's appropriate or not. As far as the Winters formula is concerned, 1.5 multiplied by serum bicarbonate, that is 17 plus 8 is equal to, I think you will get 17 plus 8.5, 25.5. I think 33 will be the answer somewhere. Plus or minus 2 will be the bicarbonate. So you will get somewhere around 31 to 33, 35. So that will be the range of PCO2 that you will be getting in this particular example. Or if you want to use delta formula, you don't want to find out the Winters formula, you can use that, delta formula also, which clearly tells that the change in the PCO2 should be equal to the change in the bicarbonate. So how much there is a change in the bicarbonate? It is 7. 24 minus 17 is equal to 7. There is a change in the bicarbonate, and that should be the change in the PCO2, which means normal PCO2 is 40 minus 7 is equal to 33 plus or minus 2. Still you are getting the same thing, 31 to 35. So there is no problem. So 31 to 35 is what you are getting, which means the patient is having, like within range or outside the range. The PCO2 of the patient is within the range or outside the range. 31 to 35, you mean by it's within the range or outside the range? Of course, it's within the range. So if it's within the range, then means you're having an uncomplicated single disorder, or it's only one problem. It's only metabolic acidosis, that is HUGMA. That's all. So which means I can tell the final diagnosis in this patient is only HUGMA, high ion gap metabolic acidosis. That's all, nothing else. If the patient is having HUGMA, and what is the reason for development of HUGMA in this patient? What is the reason? Why the patient is having HUGMA? I mean, there is basic idea, no? I have given a chart yesterday in metabolic acidosis. If you have a HUGMA, then what do you have to see? What is the cause? Okay. One possibility could be a diabetic ketoacidosis. That is, patient is having a glucose of 520. So you have to see ketones, but ketones is not given nevertheless. But second possibility is uremia. So even potassium, your creatinine is 3.6 and blood urine nitrogen is 58. So it could be uremia also. So there are multiple processes in this patient. I need to do urine ketones or serum plasma ketones to be precise. Or if the plasma ketones are negative, then I will be thinking that this patient is primarily having a uremic high ion gap metabolic acidosis. That is due to acute kidney injury only, or probably an acute on chronic kidney injury. So I don't think they have given any urine sodium and all. So that's fine. That's okay. Okay, all right. So this is a case of HUGMA, that's all. This is an uncomplicated high ion gap metabolic acidosis. And the patient is having associated renal failure and probable diabetic ketoacidosis. I don't have any other answer here. Clear? Fine. So any other case you want me to tell? So we have finished case 1, case 2, case 7, case 11, case 15. I have did it myself. Any other thing you want? Any other case here in this which you cannot solve? No, I think every single other case you can solve easily. I don't think there will be any problem at all. So for understanding sake, let me solve only the case number 10, because that is concerned with hyperkalemia. I think we have discussed on hypokalemia. We have discussed on hypernatremia. We discussed on hyponatremia also. And only thing that is left for completion sake is hyperkalemia. So we have only one electrolyte left, that is hyperkalemia. So I think for that matters, we can discuss on case number 10, which is having hyperkalemia. So 6.2, that's the problem there. 6.3 is the potassium. So this patient is having a hyperkalemia. And if you take the burn creatinine, creatinine, it is slightly elevated, but urea is okay. Glucose is okay, not a big deal. Protein 3+, but they're not given any other deal here. And the bicarbonate is also low, which means first go for the acid base that we have learned yesterday. So this patient is having hyperkalemia. Along with that, the patient is having acidosis. Hyperkalemia and acidosis. If the patient has acidosis, then you need to know what is the type of acidosis, NAGMA or HAGMA. So bicarbonate is 17. So you think it's a NAGMA or you think it's a HAGMA? This is a NAGMA. So here, if you find out the anion gap, it is 141 minus 116 plus 17. It is equal to 141 minus 133 is equal to 8. 8 is the anion gap. So this patient is actually having a normal anion gap metabolic acidosis. Surely they are having NAGMA. I don't think they have given any urinary values to suggest, to assume further. So since I know NAGMA, then let me see the URAD causes. So these are the usual causes, URAD. So if the patient is having URAD, so what could be the causes? So it could be ureterosigmoidostomy, or it could be renal tubular acidosis. Renal tubular acidosis, we know it's type 1 versus type 2 RTA is there. Then I'm having a type 4 hyperkalemic RTA. Then I have Addison disease. Then I have diarrhea also. So here, because the patient is having hyperkalemia, based on that, I can exclude certain causes. I can exclude diarrhea. I can probably exclude type 1 and type 2 RTA also. So which means all these conditions are basically going to produce hypokalemia. And ureterosigmoidostomy, I don't think they are going to cause hypo or hyperkalemia most of the times. We can leave that off from the expression. That's not very important in our understanding. Either my diagnosis must be a type 4 RTA or my diagnosis should be a Addison disease. So this is what my diagnosis should be. But if I'm having an Addison disease, I will not be having this much of sodium. So this much of sodium is not possible, because Addison disease we are talking about is a primary adrenal insufficiency, which means it's usually a salt wasting state. Basically, this is a salt wasting state. So in a salt wasting state, logically, commonsensically, seeing a sodium of 141 is not very suitable. So I don't think it's likely. It's going to be extremely unlikely in this situation. So my probable diagnosis will be a type 4 renal tubular acidosis. That is going to be my probable diagnosis. So usually I'll be thinking about type 4 renal tubular acidosis in this setting. So that also has a reason, because I'm having glucose of 189 and my patient is having a creatinine of 1.6 and I'm having a 3+ protein, which means I'm having a proteinuria and I'm having a glucose of 189 and I'm having a creatinine of 1.6. This clearly again tells you that this type 4 RTA must be due to something called a diabetic nephropathy. That's the reason. That's the likely reason. Logical reason here is diabetic nephropathy. That is the reason why the patient is having proteinuria. That's the reason patient is having a high glucose, and that's the reason having a marginally elevated creatinine, like 1.6. So this is probably a type 4 RTA patient who's basically suffering from a diabetic nephropathy. Because I don't have any history of NSAID use or beta blocker use, so I can conclude with the available numbers and with the available data, I can conclude that this patient is likely having a diabetic nephropathy, and seeing a high potassium in diabetic nephropathy is an extremely common entity. Or if the patient is having any drug use like NSAID use, I'll be thinking about NSAID related hyperkalemia. Or if the patient is using any ACE inhibitors or ARBs, of course I'll be thinking about ACE inhibitor ARBs. Or the patient is having spironolactone, I'll be thinking about spironolactone also. But because I didn't have any proper history in this setting, I'll be thinking about a diabetic nephropathy only. I think you can get this. It's an easy case only. There's a case of hyperkalemia. So, but I discussed on this is to tell how will you approach hyperkalemia. That's very important. So to approach hyperkalemia, whenever you have a high potassium, there are two reasons why you can get a hypokalemia. One is a low GFR or some transcellular shift causes are there. So first always see the GFR. If the patient is having a low GFR, in the sense like patient is not having sufficient kidney function, then always think about AK and CKD. This is the topmost cause of hyperkalemia in the world. If they ask you number one cause of hyperkalemia in the world, it's always AK and CKD only. pathological cause, or it could be drugs. So if the GFR is okay, then think about any drug intake. Drugs like ACE inhibitors, ARBs, spironolactone, eplerenone. These are again extremely common causes in the world. So if if yes, then again it's a drug-induced hyperkalemia. You try to stop the drug. If the drug is not there, then now there could be some issue, which means you need to start evaluating. Then in that setting, you can see urinary potassium or urinary potassium creatinine ratio. The urinary potassium creatinine ratio is high or urinary potassium creatinine ratio is normal. The urinary potassium creatinine ratio is normal or decreased, then definitely it's a renal problem, because in the setting of hyperkalemia, if I'm seeing a low urinary potassium or potassium creatinine ratio, definitely that is not appropriate. Kidneys are supposed to excrete more potassium in this setting, but the kidneys are actually excreting less potassium. So I'll be thinking in more of a renal cause here. If the kidneys are excreting more potassium, then usually it will be a transcellular shift. Transcellular shift, in the sense it could be hyperkalemia due to some problems like insulin deficiency, or there is something called a hyperkalemic periodic paralysis. So some problems, that is an example of a transcellular shift, which is a very rare cause. So if you think about a renal cause, yesterday itself, I think I've told you the algorithm for renal cause. So whenever you think about a renal cause, you need to know whether it's a low renin cause or a high renin cause. So to separate that, whether it's aldosterone deficiency or aldosterone resistance first, then I need to give a fludrocortisone test in this setting. Fludrocortisone test. So I'll give an injection of fludrocortisone for 2 to 3 days. Then I'll check the TTKG again, which means whether it's improving or whether it is remaining the same. It is resistant. If TTKG is more than 7, which means it's improving to fludrocortisone, means I'm talking about an aldosterone deficiency here. Even after giving fludrocortisone, if it's not improving at all, I'm talking about an aldosterone resistance here. Aldosterone resistance, many causes are there, right from the drugs like NSAIDs, beta blockers, calcineurin inhibitors, to conditions like connective tissue disorders, to conditions like sickle cell disease, HIV. So many conditions are there. Anything can produce aldosterone resistance in this setting. Or drugs means we are talking about potassium sparing diuretics, ENaC blockers, or mineralocorticoid receptor antagonists. We are talking about that kind of drugs, which I've discussed yesterday itself. Usually that will be the usual reason, but that's why I'm telling you, initially itself you see those drugs. Why you want to go till the end? There's no point in evaluating. If there is a drug that is known to cause hyperkalemia, first stop the drug and recheck the potassium after some time. Most of the time that will be the usual reason. If it's aldosterone deficiency, then see the renin. If it's a low renin aldosterone deficiency or a high renin aldosterone deficiency. If it's going to be a low renin aldosterone deficiency in this particular setting, there is some problem in the kidneys production of aldosterone. So it must be due to some drugs like, for example, NSAIDs. Once again, it must be due to some diabetic kidney disease, that is diabetic nephropathy, DKD could be the possibility, or anything else that damages the interstitial area like HIV, calcineurin inhibitors once again. So we discussed yesterday itself. If it's a high renin, then which means renin is there, but the adrenals are not responding. So very likely in exam, it will be an adrenal insufficiency in this setting, or could be again drugs like ACE inhibitors, ARBs, or even heparin. So this is what the usual cause will be in this particular setting. So that's why I'm telling you, at every stage, like a lot of drugs are causing the problem. Always rule out drugs first. When the patient is not having any history of this kind of drug-induced hyperkalemia, then you start evaluating, because otherwise there is no point. If there is certain drug that can produce hyperkalemia and the patient is taking for sure, then remove that drug from the regime and then you recheck the potassium. Then only you can think about probably the CTD, sickle cell, adrenal insufficiency, DKD, HIV. All these things are later only, not if you have a clear-cut history of some drug that is causing a hyperkalemia. Not in that case, you need all these things to get evaluated. So this is how we evaluate a hyperkalemia. As far as treatment is concerned, the first thing that you need to see is whether the patient is having ECG changes or not. As far as hyperkalemia is concerned, if yes, you need to go for urgent treatment in the setting of probably I'll be giving a 25% dextrose with insulin, or 50% dextrose with insulin, because insulin pushes the potassium into the cell by stimulating the sodium potassium ATPase. Or I can use plus other standard therapy plus repeated beta-2 agonist. nebulizations I can use. This is an initial strategy. And before that, I need to give IV calcium gluconate. IV calcium is the first line treatment in this setting because I'm having EC changes. I'm talking about, I thought it's not EC change. So if there is an EC change, this will be the first treatment because that is to stabilize the membrane to prevent any development of arrhythmias. That's the first treatment. Then if the EC changes are not there, or once you have given IV calcium, then you can go for definitive treatment. Based on definitive treatment, I can divide into two things. Two types of drugs. The drugs that produce definitive treatment of hyperkalemia can be divided into either those drugs that produce transcellular shift of potassium, drugs that produces transcellular shift of potassium, or second possibility is drugs that produce loss of potassium from the body, which means they are going to reduce the total body potassium. I can divide into two kinds of drugs. Drugs that produce transcellular shift of potassium will have only a temporary effect, which means once the drug effect is gone, again the potassium that has gone into the cell is going to come outside the cell and they're going to produce a rebound hyperkalemia, which means in this setting there is a risk of significant rebound hyperkalemia. There are two problems with this, but nevertheless in urgent scenarios you have to use these drugs. So what are the drugs you can use? Beta-2 agonist, IV or nebulized in the form of salbutamol. Terbutaline IV also can be given. So you can give beta-2 agonist. One of the commonly used form is nebulizations repeatedly every 20 minutes or 1 hour once you keep giving, which can push the potassium into the cell. Or you can use other drugs like, for example, insulin, like insulin plus dextrose, very commonly used in our setting, either a 50% or a 20% dextrose. Insulin is a powerful activator of sodium potassium ATPase, or you can use a soda bicarbonate. Remember, one important point with respect to soda bicarbonate is that soda bicarbonate will work only in the setting of a renal failure. Only if the patient is having an AK or CKD, plus if the patient is having acidosis, only in that setting, that is in the setting of pH less than 7.3 plus hyperkalemia, soda bicarbonate is likely to work. In the absence of acidosis, especially the acidosis is very important. Acidosis and hyperkalemia only, soda bicarbonate will work. If the patient is not having acidosis, then soda bicarbonate will not work for sure. That's very, very important. If the patient is having a normal bicarbonate, don't attempt to give. If the patient is having a normal pH, don't attempt to give soda bicarbonate. It will not work. Soda bicarbonate will work only if the patient is having acidosis and hyperkalemia, especially in the setting of a renal failure. It might work. Otherwise, it won't work. Conditions that reduce total body sodium. There are two types of drugs in this group. One is those that can remove corporeal removal, which means from the body you can remove, or second, you can remove extracorporeally. Corporeal removal means you are going to remove through GI tract, which means you're going to use some potassium binding resins. There are basically 3 potassium binding resins. 2 is very commonly used. One is the SPS, that is sodium polystyrene sulfonate, called as Kayexalate. And the second is you have Patriomer, which is also very commonly used in our country. Third is sodium zirconium cryosilicate, which is not yet available commercially in many places. But the most effective of all is the sodium zirconium cryosilicate only. That's the most effective. The most non-selective is the SPS, most non-selective, and the one with highest side effects is SPS only. But still, because of cost-related problems, that is the thing that we are going to use. And at the same time, a lot of side effects are there, but one side effect they will ask you, that is colonic necrosis. In high doses, they can result in development of colonic necrosis. And second point, what they will be asking you is this SPS and Patriomer works only in the distal part of the intestine, whereas sodium zirconium cryosilicate acts both in the proximal and distal, which means colon is the primary site of action for SPS and Patriomer. But sodium zirconium cryosilicate can happen throughout the intestine, proximal, distal, small intestine, large intestine, everywhere it can act. That's why it's more effective. And if they ask you for acute chronic hyperkalemia, for both what binder can use, you can use sodium zirconium cryosilicate, whereas SPS and Patriomer can be used only in chronic hyperkalemias like CKD. You cannot use those in acute hyperkalemias. And extracorporeal removal, the most important is hemodialysis. That's all. Dialysis is the best way to remove is the best way to remove potassium overall, which means the best, fastest, and the most reliable way to remove potassium from the body and permanently from the body is also dialysis only, extracorporeal removal. That's the best way and the fastest way. But till you take the patient for dialysis, so these other strategies might be helpful, like these transcellular shift strategies, giving IV calcium gluconate. This might work. But remember, IV calcium is something that has no effect on calcium. Siddharth asking if the patient is having acidosis and hyperkalemia, patient is planned for HRE, it's imperative to give IV bicarbonate. Again, depends whether it's a patient is having ECG changes or the patient is not having ECG changes. If the patient is having ECG changes, then I will look on all these things. I'll give still bicarbonate. The patient is not having ECG changes, then probably I might be thinking about maintaining with the potassium binder itself, because it's a chronic, long-standing hyperkalemia, and the patient might be further on subsequently planned for dialysis. So again, you have not told one important data whether the patient is having an AK or a CKD. The patient is having an acute kidney injury, then probably I can give a soda bicarbonate, not a problem. If the patient is having a chronic kidney injury, which means CKD patient having hyperkalemia, I'll take a little relaxed because it's a chronic condition. So they'll have chronically hyperkalemia, and without ECG changes, I don't really want to treat this kind of urgent drugs in that scenario. Again, it's a rational. It's based on your ability to understand the clinical scenario, whether you want to treat it very urgently or we don't want to wait, depending on ECG changes, whether it's AK or CKD, how sick the patient is, and that will depend on a lot of scenario. But in exam, I don't think they will complicate this much things because they know you are kids and they don't want to ask this much questions. That are clinical decisions, whatever you're asking. Nevertheless, so the most effective way is the extracorporeal removal, that is hemodialysis, best and the fastest way. And one area where it will not work, that extracorporeal removal will not work, is your digoxin-induced hyperkalemia. In digitalase-induced hyperkalemia, you can use hemodialysis, but hemodialysis will not be effective and helpful because digoxin is not dialysable drug. That's why you cannot use hemodialysis if it's a digoxin-induced hyperkalemia. In that setting, the best treatment will be digibind, not any of this treatment what we are giving. So that's one exception that you need to know for sure. I think this must settle the debate, and we have discussed on case number 7 as well and case number 10 as well. So that must be easier now. Okay. So why I've given this kind of case studies is because you will be expecting every case in your life to have this kind of scenario, the pH, bicarbonate, CO2. So whenever you ask a final year student or whenever you ask an intern or a post-intern, their entire ABG will revolve around only these 3 values. The idea is to tell that it's not about these 3 values. Even without CO2, even without your pH value, you can make a diagnosis. Just by looking at the patient and looking at the other values, it's okay to tell. So that's why the entire idea of this 15 cases is just to make you believe that it is not only about the pH, PCO2 and bicarbonate. Because if you ask any NEET PG aspirant, if they talk about ABG, they'll think about only pH, PCO2 and bicarbonate. That's all. Their entire ABG is over. They don't want to think of anything else that's happening in the world. That's why it's not like that. In reality, we don't use that at all. We just use the common sense and we just use the basic understanding of the disease and make a diagnosis and start treating it. That's all. So this is a very practical scenario I told you. Hope these 15 cases, whatever I've given you, will be useful. That's why I don't want to complicate this stuff. So it might have looked complicated yesterday, but all these are perfectly easy and so simple to deal with. And let me give you some other problems also. You're going to answer it fast. So certain problems. Cause of low ion gap in ABG. I mean, low ion gap ABG is generally very rare. It has been described in certain scenarios. Low ion gap, especially with ammonium chloride ingestion. They have told there is something on low ion gap, but in reality, I don't really think there's any need to worry about that. In exam, they won't really ask, and even in reality, they don't really help that much. Yes, in multiple, few conditions are there. Paraproteinemias, any paraproteinemia, the light chain gammopathy, or multiple myeloma for that matters, which is also the same scenario. So you might get a low anion gap, but who's going to diagnose a paraproteinemia based on the low anion gap? Again, that has no clinical value, according to my understanding. Let me see this one. And okay, I'll show you one more image only. That could be a potential question in the exam. So they might be asking you this kind of an image also. This is a nomogram that is used for ABG, and you can go through the nomogram later on. I mean, this is quite brilliant, you know, like one side, I mean, this is not useful for mixed conditions, but it will be useful for single disorders most of the time. Mixed, it's very rare, even though it is given mixed here, but it's having a low sensitivity for finding out a mixed disorder. But this is a good nomogram. So if you plot, let me add this, then you will understand. Let us add this. Okay. If you see, they would have given bicarbonate on one side, they would have given pH on other side, and they're given the carbon dioxide also on other side. And interestingly, if you see, they would have given the least carbon dioxide is 10 only here. Please understand the fact that they are correct. And many students do think, I'll put in this side. Okay. The least carbon dioxide they have put is 10 here. You'll be seeing why 10 is the least value, but they are correct. It's not like you can wash out carbon dioxide to 0. There is a limit for how much carbon dioxide you can wash out despite how much ever you hyperventilate. There is a limit for that. You cannot reach a carbon dioxide of 0, which means the least carbon dioxide that you can reach despite how much ever you hyperventilate is 10. So that's why they stopped at 10. You cannot go. But bicarbonate can go up to 0 also. That's why cleverly they have given bicarbonate up to 0, but carbon dioxide they would have stopped at 10. That is why whenever in exam you see a PCO2 value of 8 or probably PCO2 value of 5, anything less than 10 if you see in exam, that's actually a cooked up question, which means the examiner doesn't know that this particular entity and they have made up a question. That's what it means. You can never, in reality, you cannot get a PCO2 of 8 or 7. It will be 10 and above. The least you can reach is PCO2 of 10. That's one point that you need to know. Apart from that, if we take this nomogram, you have just plotted. For example, yesterday's question, we'll take it. We had a pH of 7.29, I guess. Then we had a bicarbonate of 14 and PCO2 of 29. So this is the, I think, question we discussed yesterday. If you plot this values in this, so for example, pH of 7.29 is probably somewhere around here, and PCO2 of 29, I think it's somewhere in this line. So this 29 means it's going to go in this line only. So this is the line I'm going to follow if it's 29. So then PCO, I mean, bicarbonate of 14. 14 means it's somewhere here. So if I'm going to connect all this, so 14, if I put like this, it will be here. And 7.3, if I take from here, 7.29, it will be at this point. So you can see at what point they all are going to correlate. So they are going to meet at a point where it's a single uncomplicated metabolic acidosis. So using this nomogram, you can straightforward tell. I mean, this nomogram is an example. I mean, it saves your time. So they have plotted this and they have given the graph for our sake. If you are going to use the nomogram, then it's fine. So then they will tell this is a single uncomplicated metabolic acidosis. We know that. We have found out that yesterday itself. I think that must be fine. So I told you an example. That's all. Do you understand the nomogram? How to use the nomogram? Just for one example is enough. Yes. Then there are some other methods also for ABG. One important method they might just ask as an MCQ is something called a Stewart method. Stewart method is there that is based on something called a strong ion difference. In reality, we don't use that. Once again. So if they ask you what do you mean by Stewart method, it's another method for analyzing acid-base balance and acid-base gas analysis that basically uses something called a strong ion difference. That one point, that's enough for exams. Nobody is going to ask what is strong ion difference and what do you basically mean by Stewart method. Well, we can discuss, but not now. So that's completely a low yield information as far as our understanding is concerned. And if you have, I'll give you 10 minutes of time. So if you have any problems on your own, if you want to discuss any problems from your end, you tell me. I'll give you some 3 minutes or 2 minutes of time if you want any problems. Otherwise, we'll give a break. If you want any problems from your side, you tell me. If you want to tell, we'll solve right now here itself. Anyone has any problem? Bund creatinine ratio interpretation is something we have to discuss in the kidney. We didn't discuss AK and CKD yet. Saurav Sinha is asking drawing blood for ABG analysis. Typically, currently we have pre-filled syringes, and this question is currently I feel it's a nonsense because you're not asking because it's asked in exam. That's why you're asking. I'm not talking about you. Why this question is not correct is because we have pre-filled syringes right now. Pre-filled heparin syringes are there. That is the one we are going to use for ABG. On the other hand, if they ask you about the syringe, how much heparin to take, that's again a kind of a bluff because we don't take that particular amount of heparin. Instead, we just wanted to flush the entire syringe with heparin, which means we take the heparin, maybe 0.5 ml, even 1 ml you take, no problem. Then just flush the entire syringe with to and fro motion with heparin. Then just push all the heparin as much as possible out. Then draw the sample. So which means whatever heparin that is sticking on the sides of the needle and in the sides of the syringe wall is enough for actually ABG, arterial blood gas. But currently we have some syringes called pre-heparinized syringes. So that doesn't make any sense. If you're asking which area you should use for ABG analysis, typically I'll prefer this radial artery as the best side because radial artery has the maximum advantage. Why? Because it is supplied by another collateral ulnar artery. So even if it is occluded for some time, not a big problem. Unlike femoral artery, which is having a higher risk of dissection, higher risk of thrombus formation, and there is no other collateral artery that is supplying the lower limb along with the femoral. So femoral basically has a higher risk compared to radial. So always we prefer radial. And femoral artery is closely accompanied by the femoral vein. So many times you know that vein structures in anatomy. So when you poke the femoral artery accidentally, sometimes you might take the blood from the vein instead of the artery. So these kind of problems are there with the femoral area. But in the radial area, you generally don't have any accompanying vein and that big vein to accidentally take a blood from that. So usually whenever you collect a blood in the radial area, it's likely to be a arterial blood only. So that's why another advantage of radial side. So you are going to prefer radial side. But before preferring radial side, always perform a Allen's test. And many students eat my brain asking in many times, what is Allen's test and what is modified Allen's test? There is literally no difference as far as you know in literature. Allen's test means you are going to test both the patency of ulnar and radial artery both together. That is Allen's test. In modified Allen's test, to save time, we just check the patency of the ulnar artery. That's all. We're not going to check the patency of the radial artery. For example, original Allen's test, what you do is you just press both the ulnar and radial vessels, and you ask the person to alternatively close and open the fingers to and fro like this. So now what you do is first you remove the radial artery and see. Now if the redness comes back, it means the radial artery is patent. Now the same thing you have to repeat for ulnar artery. Now you just ask the patient to do the same thing again. Then now in this setting, you remove the ulnar artery. Now if you see, now the redness comes back again. And now it is called as now you can conclude that ulnar is patent. But as far as the modified Allen's test is concerned, for ABG analysis or probably for PCI purpose or coronary angiogram, we prefer the radial artery. So radial artery anyway we are going to poke. So that's not a problem for us. We need to know the patency of the ulnar vessel. That's the most important here. Because ulnar vessel is not patent, then we cannot poke the radial. If that is also going for damage, means the limb will go for ischemia, the hand will go for ischemia. That's why in this setting, you do the same Allen's, same way. But in this setting, only leave the ulnar artery and see for the redness to come back. So, of course, if you check only for the ulnar patency, that is something in the literature called as modified Allen's. That is for the faster approach. And if you want to test both the radial and ulnar patency, that's the original Allen's test. And that's something very commonly asked, but I don't think that makes any real difference in practice. Again, knowing about modified Allen's versus original Allen's test. And we prefer radial, of course. Most of the time in our hospital, we do ultrasound and then we take the blood for ABG also. We don't blindly poke the radial artery. We use the vascular probe of ultrasound. Then only we'll take the ABG. So plasma renin level has to be checked for all if there is hyperkalemia to rule out differential causes. Kritika is asking. So remember, as far as hyperkalemia is concerned, I clearly told that most of the times you don't even need this kind of fludrocortisone testosterone. Why? Because if you have a AK and CKD as your example, most of the times this will be the cause. And even most of the times this will be the cause. Either this or this, that's all. Usually this is the thing you're going to encounter. very, very rarely you're going to encounter a situation where you don't have a kidney injury and you don't have a drug-induced hyperkalemia. Then in that setting only you're going to go for all these things. Otherwise, there's no point in doing all these things. So only when you think it's an aldosterone deficiency, not caused by drugs, not caused by any other problem, then you can think about a renin-related problem. And even, for example, if you ask about adrenal insufficiency, most of the times in adrenal insufficiency, we have other evidences. Like, for example, patient will be having a low cortisol. So you're going to think about that only, rather than just straight away doing a renin value. I don't really do a renin value, and I'll be generally thinking about doing a cortisol value that is having more value compared to the of renin. So that's what I'm trying to tell. So try to be little sensible, even though these algorithms are there in practice, but whether you practice really or not is not, is a big question. And it's only about our knowledge and common sense. The same thing can be told in multiple different ways. That's why I don't really care. Suppose if somebody, like circulates my notes, or somebody gives my recordings to someone, that's bad on their part. They don't do that because of the copyright and all. But I don't really take it in a very big deal, because the same thing I can tell it in multiple different ways. Tomorrow I can tell the same thing in an extremely different approach. So that doesn't change anything, because once you have sufficient confidence in your knowledge, then all these things really does not matter. And medicine is something like infinite kind of thing. That's what I believe. So nobody can steal your knowledge, or nobody can try to copy whatever you have. When you have a limited knowledge, then there is a problem of copying and doing. And when you don't have that kind of poor confidence on you that you have limited knowledge, then there is no problem here. You can approach in any possible way in a patient. So all you need is to understand the patient, understand the situation. That's all. Nothing else is needed. Renin is not needed for all the patients. It's just for the algorithm's sake. It's just to complete the hyperkalemia algorithm. I have given this thing. And most of the time, these algorithms will help you understand. That's all. In practice, it can be completely different. Anything else? Okay. No, all right. So if you're not having any issues with ABG analysis, then let us move on. And you can go for a break and come back at 4:30, so that we'll start the session again for another 3 hours. We'll be discussing on AK and CKD today. So that time, I think Keshav was asking burn creatinine ratio. So that time we'll discuss about burn creatinine ratio. Not now. Bye-bye.